Yeah, I hope I'm audible to each one of you now. Good evening. So, good evening, guys. I'm Dr. Omkar, and today we are here for a quick rapid revision session of ENT by AFMG. So, let's start with our discussion further for ENT today. So we'll be rapidly revising all the important topics in ENT via a test and discussion pattern. So here in this test, I have tried to include all the important questions which have been repeated in the previous exams of FMGE and NEET PG 2021 also. So let's start with our discussion. I hope all of you will keep answering in the chat box. Due to some instances, we were not able to conduct offline class today. But nevertheless, I hope all of you will keep answering over here in the chat box. And if I'm audible, my video is clear, we can start, right? So let's start with our discussion for today, guys. Do answer in the chat box. Yeah. So now, starting with our first question, there were 35 questions and we'll try to wind them up as soon as possible. So in a shorter frame, we will try and wind up ENT because we have revised it earlier. Okay, so let's start with our discussion now. So the question one states, guys, a 14-year-old boy presents with complaints of nasal stuffiness and recurrent epistaxis. On examination, you suspect proptosis. The patient is most likely suffering from. So here we will need to give a diagnosis. So they are actually asking us about a diagnosis. So again, a clinical question. So the pattern to read a clinical question is you need to read the first line, the last line first. That is, the patient is most likely suffering from. That means we need to give a diagnosis. Everybody has started answering. Very good. So please remember, we need to find the diagnosis. Here they are saying a 14-year-old boy. That means an adolescent boy presenting with complaints of nasal stuffiness and recurrent epistaxis. And you suspect proptosis. Proptosis means protrusion of the eyeball, right? And the patient is most likely suffering from. Very good, all of you. The answer to this question is option A, nasopharyngeal angiofibroma. Okay, why do we rule out other options? So please remember, maxillary sinusitis can present with symptoms of nasal stuffiness, nasal obstruction, okay, or most likely it presents with nasal discharge or a postnasal drip. Okay, it is an infectious condition, but it does not present most likely with epistaxis or proptosis. Therefore, it can be ruled out. Next is Potts-Purphy tumor. It is a complication of frontal sinusitis. We'll see it further what is Potts-Purphy tumor. Okay, so as it is a frontal sinusitis, it does not commonly involve the nose. Therefore, no chances of recurrent epistaxis as such are seen in Potts-Purphy tumor. We are left with both of these are actually tumors of the pharynx, right? Important. But nasopharyngeal carcinoma usually involves adult males. Okay, please remember, nasopharyngeal carcinoma usually involves adult males, okay, and it is associated with the Epstein-Barr virus infection. So there can be a history of EBV infection prior to that, okay, important one. Whereas nasopharyngeal angiofibroma, it is most likely the diagnosis over here because it commonly affects adolescents boys and it has the same features like in the question given below. So please remember, if we talk about the juvenile nasopharyngeal angiofibroma, these are the important points that you need to remember, okay. So please, am I audible, guys, to each one of you? I hope there is no internet issue over here. So if I talk about juvenile nasopharyngeal angiofibroma, juvenile itself means adolescents. Okay, usually children between 11 to 18 years of age group. Okay, so please remember, the most common age in which nasopharyngeal angiofibroma is usually seen, it is the juvenile or the adolescent age group. Okay, the juvenile or the adolescent age group, important, and it is more commonly seen in which sex? So please remember, it is more commonly seen in boys. Okay, it is more commonly seen in boys, important one. I hope I'm audible. The video isn't tracking, right? So moving further, then from where do the juvenile nasopharyngeal angiofibroma originates? So this is an important one-liner that you need to remember. So please remember, the juvenile nasopharyngeal angiofibroma, it usually originates from the sphenopalatine foramen. It usually originates from the sphenopalatine foramen, important. So juvenile nasopharyngeal angiofibroma originates from the sphenopalatine foramen. Then Juvenile nasopharyngeal angiofibroma. Angio, that means a vascular tumor. Okay, so please remember it is a vascular tumor. Therefore, in cases of any vascular tumor, I have always told you biopsy is absolutely contraindicated. So please remember biopsy would not be the investigation of choice in cases of juvenile nasopharyngeal angiofibroma. Therefore, biopsy is absolutely contraindicated. Okay. This is a picture that you can see. This is a child, a 14 or 15-year-old child would most likely present to you. Okay. Along with some, why is it lagging? Just a minute. I'll try to, I hope now it is fine. Excuse me. लैग हो रहा है एक हाँ हाँ एक बार कर दीजिए I hope it, I hope it's fine now. Now is it fine? Please let me know. If it is, then I can proceed. Now I hope it is fine, right? So yeah, let's begin again with our discussion. Okay, great. So we were discussing about nasopharyngeal angiofibroma. It is a vascular tumor commonly seen in adolescent, mainly in boys. Okay, it is more common in boys. And the child would present to you with nasal stuffiness, recurrent epistaxis, because these vessels are more fragile, the tumor vessels, and they are more likely to bleed. Therefore, recurrent epistaxis is a common feature. The most common site of origin would be sphenopalatine foramen. Okay, biopsy is absolutely contraindicated because it is a vascular tumor and there can be profuse bleeding if you perform a biopsy. Therefore, a CT is recommended. A contrast enhanced CT scan usually will show us that the posterior wall of the maxillary sinus is pushed ahead, and this sign has a very characteristic name. This is known as the, anybody? This sign is known as Holman-Miller sign. Please remember, this sign is known as Holman-Miller sign. It is also known as the antral sign. It is also known as the antral sign. So which sign on CCT is seen in nasopharyngeal angiofibroma? Important two features. On CCT we can find Holman-Miller sign and antral sign. Holman-Miller sign or antral sign. Yes, very good. Cardiovascular. Yes, this deformity here, the characteristic feces that we see due to protrusion of the eyeball and a mass. Here it is also known as a frog face deformity. So please remember, this feces is also known as a frog face deformity. Very good. I hope everything is clear with this. If it is, then I can move forward. Okay, then talking about the next option that we had, that was Pott's Puffy tumor. And as I already told you, Pott's Puffy tumor is actually a complication of frontal sinusitis. Okay, Pott's Puffy tumor is actually a complication of frontal sinusitis. Okay, here so you can see, please remember, whenever a patient has frontal sinusitis for a longer period of time, then that can land up the patient in osteomyelitis of frontal bone, right? So from the sinuses, the infection might spread to the frontal bone. It will involve, along with the sinus, it will involve this frontal bone, and there would be osteomyelitis of frontal bone. And this osteomyelitis of frontal bone, guys, is actually known as this Pott's Puffy tumor. Important? Yeah. A subperiosteal abscess is usually formed in cases. As the abscess is formed, it will also further involve the bone, that is your frontal bone, and there would be osteomyelitis of this bone, known as Pott's Puffy tumor, right? One more thing to be remembered about frontal sinusitis, important thing, frontal sinusitis usually presents with which type of headache? So frontal sinusitis commonly presents with office headache from 9 to 5, okay? So usually it presents with office headache. Along with that, we can also see a benign bone tumor in cases of frontal sinusitis commonly, and those are known as osteomas. Those are known as osteomas. I hope these two things you remember about frontal sinusitis. First, ऑफिस हेडेक के साथ प्रेजेंट करता है, एंड सेकंड osteomas are more commonly associated with frontal sinusitis. Moving further to next question now. I hope it was fine. Question number 2 says, guys, a 26-year-old pregnant female suffers from bilateral hearing loss which worsened during pregnancy. A very important punchline. The audiometry shows the following picture. So this is your pure tone audiometry, PTA finding that is given below. Which graph will most likely be seen on tympanometry? So now they have given a picture of PTA, pure tone audiometry, and now they are asking us a graph of tympanometry. But before moving further, we actually need to know a provisional diagnosis. So what is the provisional diagnosis? So please remember, whenever a young adult female presents to you with bilateral hearing loss, which definitely worsens on pregnancy, okay, aggravating factor is pregnancy, this is now none other than otosclerosis. This is a very characteristic picture of otosclerosis. Young adult female suffering from bilateral conductive hearing loss which worsens even more during pregnancy. This is a picture of otosclerosis, right? But let's confirm it from the PTA too. So on PTA you can see, so this is a pure tone audiometry, guys. How to recognize? So please remember, here you can see two waves. The first one, the first line that you can see, that is your bone conduction line, and the second one below that you can see is your air conduction, right? Important one. So please remember, bone conduction will tell us about sensory neural hearing loss, whereas air conduction will tell us about conductive hearing loss. Okay, air conduction will tell us about conductive hearing loss. So usually both of these lines should be about 25 decibels. Okay, both of these AC as well as BC should be about less than 25 decibels. If they are more than 25 decibels, they suggest, I will definitely give you the PDF. Okay, so if these AC or BC lines, they are about 25 decibels, they suggest that there is a hearing loss. So if they are below this level, they suggest there is a hearing loss. So here we can see that the BC line is about 25 decibels. Okay, so it is just beneath 25 decibels. So there is no issues with sensory neural hearing loss. Here only the here only the air conduction is dipping down. Okay, and if air conduction is dipping down, that is suggestive of a conductive hearing loss. And as we all know, conductive hearing loss is usually seen in cases of otosclerosis. First feature you can recognize. And a second very important feature, in bone conduction, guys, you can see a dip. Okay, in bone conduction, you can see a dip at 2000 hertz, right? In bone conduction, if you see a dip at 2000 hertz, this is known as anybody? A dip in bone conduction at 2000 hertz is known as, I hope all of you are quite aware of this. So a dip in bone conduction at 2000 hertz is known as the Carhart's notch, right? It is known as the Carhart's notch. And Carhart's notch is a very characteristic audiometric feature of otosclerosis, right? Yeah, very good, guys, very good. I hope this is fine now. So सबसे पहले important things to be remembered in a pure tone audiometry, both the lines should be beneath 25 decibels. That means there is no hearing loss. If one of the line is also below about 25 decibels, that suggests there is a hearing loss. Okay, if AC is below, that means there is conductive hearing loss. If AC and BC both are more than 25 decibels, then it suggests there is a sensory neural hearing loss. I hope this is fine. And in otosclerosis, usually you see a 2000 hertz dip in bone conduction. This is known as the Carhart's notch, a very specific feature of otosclerosis, right? And now as we have come to a diagnosis, it is otosclerosis. Now can anybody tell me what is the curve that we can see on tympanometry? I hope all of you have answered it quite well. Yes, we can see option A, that is a AS type of curve in cases of otosclerosis. A AS type of curve is seen in cases of otosclerosis. Let's discuss some important features about otosclerosis. So as we all know, what is otosclerosis, guys? It is nothing but, please remember, it is usually a gradual, okay, it is usually a gradually progressive conductive hearing loss. Okay, please remember, otosclerosis is nothing but it is a gradually progressive conductive hearing loss. It is also known as otospongeosis. So otosclerosis is also known as otospongeosis. Okay, and it is a gradually progressive conducting hearing loss. Why does it occur? There is an important feature in the name itself. Otto means ear, sclerosis means there is fibrosis. And where is actually the fibrosis? So as we all know, right? So here is the stapes. Okay, this is the stapes suprastructure. This is the stapes foot plate, and this stapes foot plate will attach to the oval window of the inner ear. So at this attachment, there is fibrosis all around this. Okay, there is fibrosis all around this, and that's the reason why the stapes could not move. The ossicles could not move properly, and if the ossicles could not move, then therefore there is fixation of the stapes, which cannot conduct the sound further. Okay, this is due to fixation of the stapes. I hope this is fine with everybody. Then, as we have discussed already, otosclerosis is more commonly seen in, as we are quite sure, otosclerosis is more commonly seen in young females. Otosclerosis is common in young females, mostly in their second or third decade. In their second or third decade. I hope this is fine. Then, otosclerosis is commonly aggravated by which factor? As in the question also they had given, otosclerosis is commonly aggravated by pregnancy. So, a female who is suffering from a gradually progressive CHL, the condition would further worsen if she is pregnant. Okay, so aggravating factor is pregnancy. Most common site of origin is just ahead of this oval window, and it is known as fistula antefenestrum. So, a very important one-liner. So, which is the most common site of origin of otosclerosis? Fistula antefenestrum. Which is the most common site of origin of otosclerosis? Fistula antefenestrum. I hope this is fine. Everybody remembers this. Then, the phenomena which is usually seen in cases of otosclerosis, here the patient here the patient would hear better in noisy areas. Okay, so please remember, when there is loud sound or in cases of noisy areas, the patient would hear much better, and this phenomena is known as Paraacousis willisii. Very good. This phenomena is known as Paraacousis willisii. Very good, great. Then investigation would be a pure tone audiometry, and as we already saw in pure tone audiometry, we find a dip at how much hertz? Dip at 2000 hertz, and this dip at 2000 hertz is known as what? This is known as the Carhart's notch. It is known as the Carhart's notch, right? And treatment of choice would be what? Anybody? Treatment of choice in cases of otosclerosis. Now the stapes foot plate is fixed. There is fibrosis. Now you need to open it, right? And this process is known as stepedotomy. This process is known as stepedotomy. So please remember, stepedotomy is preferred over stapedectomy. Okay, please remember, stepedotomy is preferred over stapedectomy. I hope this is fine with everybody. And this stepedotomy is usually performed with the stapes prosthesis. That means we remove the original stapes and we actually put a prosthesis. Okay, we actually put a prosthesis. I hope this is fine. Right. Then if we talk about tympanometry, guys, you need to know about tympanometry because this image have been asked multiple times in the examinations. They always ask about tympanometry, right? So tympanometry usually has 5 curves. Tympanometry क्या assess करता है? So please remember, usually tympanometry assesses the movement of your tympanic membrane. Tympanometry assesses the movement of your tympanic membrane and the ear ossicles. Okay, their movement is assessed by this tympanometry, right? So the normal curve in tympanometry usually would be this, the type A curve. The type A curve is a normal curve. Then this one, that is your type AD curve. This type AD curve is usually seen in cases of ossicular dislocation. It is usually seen in cases of ossicular dislocation. Then the third one is your type AS curve. This one over here. Okay. This one, I can draw it for you. So this type AS curve is usually seen in cases of, very good, it is seen in cases of otosclerosis. And that was our question. And type B curve, which is a flatter curve. Type B curve is a flatter curve seen usually in cases of glue ear. It is seen in cases of glue ear, right? Whereas type C curve is usually seen in cases of eustachian tube blockage. I hope once we can revise it once again, so everybody would repeat it. Normal curve is type A curve. Normal curve is type A curve. In ossicular dislocation we find AD curve. In ossicular dislocation we find AD curve. In otosclerosis we find AS curve. Otosclerosis mein AS curve. Flat curve or flat curve or type B curve is seen in glue ear, also known as serous otitis media. And type C curve is usually seen in cases of eustachian tube blockage. Moving further to question number 3 now. A patient of neurofibromatosis type 2 has developed bilateral acoustic neuroma. So NF2 patient developed a bilateral acoustic neuroma, which is the most appropriate treatment for hearing rehabilitation in this patient. That square was for the normal hearing range. Okay, if the patient falls within that square, guys, so the patient is considered normal. Above it and beneath it, it is abnormal. So anybody? Please try to answer this question. So let's discuss it first, and then I hope you will be answering it better, because yeah. So first of all, talking about hearing aids, guys. If we talk about hearing aids are those instruments which are used to amplify sound. Okay, hearing aids are those instruments which are used to amplify sounds, used in cases of hearing loss. Okay, so here if we talk about hearing loss, as we have already discussed, if it is more than 25 decibels, it is considered as hearing loss. Okay, more than 25 decibels is considered as hearing loss. More than 25 decibels is hearing loss. Then there are various grades: mild, moderate, moderately severe, severe, and profound. So at least you need to remember profound levels, because this has been asked. So profound hearing loss is more than 90 decibels. Profound hearing loss would be more than 90 decibels. Normal hearing loss is more than 25 decibels, whereas profound hearing loss would be more than 90 decibels. So if a patient is suffering from profound hearing loss, mostly bilateral profound hearing loss, if a patient is suffering from bilateral profound hearing loss, then usually the treatment of choice would be a cochlear implant surgery. In cases of mild moderate hearing loss, we usually give hearing aids. Okay, it can be a digital hearing aid, or just a bone anchored hearing aid, or a pocket hearing aid. Anything that kind can be given. But if a patient is suffering from profound hearing loss more than 90 decibels, and that too bilaterally, the treatment of choice would be cochlear implant surgery. But what is the prerequisite for this cochlear implant surgery? If you need to perform this cochlear implant surgery, the prerequisite or the condition is that the 8th nerve should be intact. Important, the 8th nerve should be absolutely intact, because the cochlea can be changed, but the cochlea will in turn send the frequencies or the signals to the 8th nerve, right? So if you are changing the cochlea also, the 8th nerve should be intact of that patient. Therefore, the signals will travel further. Otherwise, they are of no use if the 8th nerve is damaged, right? So, whereas what happens in neurofibromatosis type 2, as we are all quite aware of the fact that NF2 patients are at a high risk of developing bilateral acoustic neuroma. And what do we mean by acoustic neuroma, guys? I hope everybody is quite aware over here. So, acoustic neuroma, also known as vestibular schwannoma, right? This is actually a tumor of 8th nerve. This is your tumor of 8th nerve, that is your 8th cranial nerve, vestibulocochlear nerve. So acoustic neuroma is a tumor of vestibulocochlear nerve, that is your 8th nerve, which is responsible for hearing, right? So in this condition, in cases of acoustic neuroma, the 8th nerve is damaged, right? The 8th nerve is damaged. Rather, it is damaged bilaterally, because here the patient has developed bilateral acoustic neuroma. Therefore, in cases of bilateral acoustic neuroma, as the 8th nerve is damaged, the cochlear implant surgery would not have any role, right? Cochlear implant surgery has an important condition, that it needs the 8th nerve to be intact. But as here the 8th nerve is itself damaged, therefore in bilateral acoustic neuroma, cochlear implant surgery has no role as such. Okay, it would be of no use. Though you perform it, the patient would have no use of it. Now, can anybody tell me the answer? Can we rule out it once? Now, has your perception changed about this question? I hope it has. So please remember, option A says bilateral digital hearing aid. It is usually used in cases of mild to moderate hearing loss. Bone anchored hearing aid, again in cases of mild to moderate hearing loss. Bilateral cochlear implant surgery, it will require the eighth nerve to be intact. But as it is an acoustic neuroma, tumor of the eighth nerve itself, therefore the eighth nerve has been damaged. So cochlear implant would have no role, and therefore the answer to this question becomes option D, auditory brainstem implant. Okay, therefore in cases of acoustic neuroma, the hearing aid of choice or the hearing rehabilitation treatment of choice would be auditory brainstem implant, right? I hope this is clear. Moving further to question number 4 now. If I'm going fast, let me know. I can just slow down my speed a bit. So question number 4 says, guys, a 20-year-old female underwent a tonsillectomy and the surgery was uneventful. After a week, the patient presents to emergency with bleeding from oral cavity. What is the best management? No, Rosie. Please remember, not for option D. You will require the eighth nerve to be intact. In option D, here you can actually implant. You are actually inserting an implant directly near the brain stem. Okay, please remember, it is usually implanted in the lateral recess of the fourth ventricle. Okay, where it is usually implanted in the lateral recess of the fourth ventricle. It directly sends signal to the cortex now. Okay, so auditory brainstem implant does not require the eighth nerve for its conduction because it is directly placed into the lateral recess of fourth ventricle, and from there it can directly send the signals to the cortex. But in cases of cochlear implant surgery, here it requires the eighth nerve for its conduction because it is usually placed in the scala tympani of cochlea. I'll explain it to you further. What is scala tympani? Sorry. Very good, very good. I hope all of you have got the logic behind this question. So please remember, here a 20-year-old female underwent a tonsillectomy surgery, right? And the surgery was uneventful. That means it was absolutely normal, no issues with the surgery. But after a week, what happens? Now the patient presents to the emergency with bleeding from oral cavity. That means there is some hemorrhage, right? So now they are asking, what is the best management for this? So first of all, let's discuss about a few points about tonsillectomy, which are important from your exam point of view. At least the one-liners. So tonsillectomy, nowadays it is usually preferred that we perform an interval tonsillectomy. Nowadays we perform a interval tonsillectomy. What do we mean by interval tonsillectomy? That means if a patient comes to you in an episode of acute tonsillitis, there is still ongoing inflammation right now, right? Therefore, you avoid to perform a surgery at that point of time. Previously it was done, but nowadays it is avoided to perform a surgery at the point of time in cases of acute inflammation. Therefore, we usually plan the surgery after 6 weeks. Usually plan the surgery after 6 weeks, and this is known as interval tonsillectomy. The method by which we usually remove the tonsils is known as the dissection and snare method. The method by which we usually remove the tonsils is known as the dissection and snare method. That means dissection and cut method, right? Now, what usually happens in cases of tonsillectomy, guys, there are chances of hemorrhage. Okay, there are usually chances of hemorrhage. Okay, so in tonsillectomy, or rather than in cases of any surgeries, this is a very important point from surgery aspect also, so you need to remember this. Okay, so hemorrhages after surgeries are usually of 3 types, right? They can be either primary hemorrhage, a reactionary hemorrhage, or a secondary hemorrhage. Primary hemorrhages are the ones which are during surgery. Okay, primary hemorrhages occur during surgery. Any hemorrhage during surgery will be considered a primary hemorrhage. Then a hemorrhage which occurs within 24 hours of surgery is considered a reactionary hemorrhage. A hemorrhage or bleeding occurring within 24 hours of surgery is considered a reactionary hemorrhage. Okay, and the most common cause of this reactionary hemorrhage would be slippage of a ligature. It would most commonly be a slippage of a ligature. Okay, you have put some suture, but the suture has slipped, and that is why the patient started bleeding within 24 hours of surgery. This type is known as reactionary hemorrhage. And the last type is secondary hemorrhage. It usually occurs after 5 days of surgery. It usually occurs after 5 days of surgery, and the most common cause of secondary hemorrhage usually is infection. Okay, and in this case, of tonsillectomy, there would be infection of the tonsillar fossa. Here there would be infection of the tonsillar fossa. So secondary hemorrhage ki most common cause would be infection. In cases of tonsillectomy, secondary hemorrhage would be due to most likely infection of the tonsillar fossa. Now, our patient was a 20-year-old female. Tonsillectomy was done after a week. Okay, this is important, the time frame. After a week, she presents to us. Definitely, it is not primary. Definitely, it is not reactionary also. So that means it is a secondary hemorrhage. And secondary hemorrhage, most common cause is infection. So what would be the best management for this? I hope all of you have got it now. Very good. The best management for this would be option B, admission and IV antibiotics. You usually start IV antibiotics to this patient to overcome that infection. I hope this is fine with everybody. Now, can anybody tell me the answer to this last statement that I've added? Which is the most common vessel to bleed in cases of surgery or tonsillectomy? Which is the most common vessel to bleed? Can anybody tell me this? A very important question that you need to remember. One liner. This question had come earlier also. The most common vessel to bleed is, in cases of tonsillectomy, the most common vessel to bleed is, anybody? So it is your paratonsillar vein. So please remember, the most common vessel to bleed in cases of tonsillectomy is your paratonsillar vein. Very good, Mahira. It is your paratonsillar vein, which is the most common vessel to bleed in cases of tonsillectomy. Okay, and there was an important question. No, please remember, it is not an artery. Okay, so please remember, tonsillar branch of facial artery is the most important blood supply to thyroid. This was a question in INS-ET. The most important blood supply to thyroid. Most important blood supply to tonsil. And the most important blood supply to tonsil is via the tonsillar branch of facial artery. It is via the tonsillar branch of facial artery. I hope this is fine with everybody. This was also a one-liner that has been asked. Most important blood supply to tonsils, tonsillar branch of facial artery. Most common vessel to bleed in tonsillectomy, paratonsillar vein. No issues with this. Moving further. Question number 5. Question number 5 states, a child presented with complaints of sore throat and fever along with bilateral neck swelling. On inspection, following picture is seen of the oropharynx. What is the diagnosis? So now the question is, what is the diagnosis? So what is the diagnosis for this condition? Anybody? All of you are right. Very good. So here a child is presenting with complaints of sore throat and fever. That means there is some infection. And he's complaining of sore throat. That means there is some pharyngitis like infection. Okay. Along with, there is bilateral neck swelling. And this bilateral neck swelling is usually due to bilateral cervical lymphadenopathy. Right. On both sides the lymph nodes are being enlarged. So therefore there is a bilateral neck swelling. If you inspect the oral cavity or the oropharynx, this is what it looks like. Okay, what is this? This is usually your pseudomembrane. What is this? This is known as your pseudomembrane. So this is a whitish pseudomembrane. So now let's first discuss what are the important causes of whitish membrane on tonsils. Right? So important causes of whitish membrane of tonsils. Most common cause is usually Streptococcus pyogenes infection. Most common cause is usually Streptococcus pyogenes infection. That leads to acute streptococcal tonsillitis. Apart from that, a Epstein-Barr virus infection. Epstein-Barr virus infection, that means infectious mononucleosis. Second most important cause is infectious mononucleosis. Third, it can also be due to Vincent angina. So these three are the most important cause of whitish membrane on tonsils. Along with that, a very important and a very common cause, that is diphtheria. Right? Whitish membrane can also be seen due to diphtheria. But what is the difference between whitish membrane of all these three diseases and the whitish membrane of diphtheria. So please remember, in diphtheria usually the whitish membrane is not only limited to the tonsils, rather it extends up to the palate as well. Right, when the whitish pseudo membrane extends up to the palate also, this is very much characteristic of diphtheria. So here it is extending up to the palate, it is covering the uvula, right? So it is very much important that it is most likely diphtheria, right? Along with that, to support our diagnosis, there is this bilateral cervical lymphadenopathy, which is a very characteristic feature of diphtheria, which will present like this in this image. The child, FMGE June 2021 question, the same image had come, okay, and it is due to bilateral cervical lymphadenopathy of diphtheria. Yesterday also we discussed it, and this is known as bull's neck. This appearance is known as bull's neck, which is a characteristic appearance of diphtheria. I hope all of you know that now. Okay, so important two features: bilateral cervical lymphadenopathy giving a bull's neck appearance. Second, pseudo membrane but extending from the tonsils up to the palate. Right. So here the answer would be option D, diphtheric tonsillitis. Diphtheric tonsillitis. Right. So talking about diphtheria, guys, diphtheria is caused by Corynebacterium diphtheriae. Diphtheria is caused by Corynebacterium diphtheriae. And please remember, diphtheria has become a very common question, even in paper 1 and also in paper 2 from the last 2 to 3 sessions. Okay, so you need to be very thorough with diphtheria. So diphtheria is caused by Corynebacterium diphtheriae. Okay, on Albert stain, this Corynebacterium diphtheriae gives which appearance? It usually gives Chinese letter pattern. Okay, it usually gives Chinese letter pattern or cuneiform arrangement. Important. Then appearance of diphtheria would be what? The patient would be most likely a child. Okay, the patient would most likely be a child, like a school age child, presenting to you with sore throat, fever, and on oral examination there would be a whitish pseudo membrane extending up to the palate, along with this bilateral cervical lymphadenopathy that is known as the bull's neck. That is known as the bull's neck. I hope this is clear. So this is all about diphtheria you need to know. Then if we talk about Ludwig's angina, just to differentiate how Ludwig angina looks like. So please remember, Ludwig angina also presents with the neck swelling. This is the neck swelling of Ludwig's angina. But usually it is a submental or a submandibular swelling and mainly unilateral swelling. Okay, it is usually a unilateral swelling, first thing. Second feature to describe it, it is a submental or a submandibular swelling. Okay, submental or submandibular swelling. Why? So please remember, what is Ludwig's angina actually? Ludwig's angina is infection of the submandibular fossa, submandibular space. So this is your submandibular space. Okay, and infection of this submandibular space is actually known as Ludwig's angina. Right? And why is this infection? So please remember, the most common cause of Ludwig's angina would be dental. Very good. It is dental caries. Most common cause of Ludwig's angina is dental caries. It can also be seen after a dental procedure also if sterility was not maintained properly. Right? So a infection of the submandibular space or just floor of the mouth, which is formed by the mylohyoid muscle, infection of this area is known as Ludwig's angina, presenting with fever, sore throat, or at times with submental and submandibular swelling. It is usually unilateral. Most common cause is dental caries, and usually it is treated by incision and drainage. It is treated by incision and drainage. Okay, from outside only we incise it and drain it properly. Okay, IND is the treatment of choice. I hope this was fine with everybody. This would lead to pseudomembrane up till tonsils. This is a completely different thing. And parapharyngeal abscess usually presents as a swelling in the neck only on one side again. We'll discuss about parapharyngeal abscess further. Moving on to question number 6. A very easy question but has been asked in August examination. This question was present. So what is the most common site of Zenker's diverticulum? Zenker's diverticulum, most common site. A question from surgery 2. Between superior and middle constrictor muscles, between stylopharyngeus and palatopharyngeus, between thyropharyngeus and cricopharyngeus, between middle and inferior constrictor muscles. Very good, very good. Yes, the answer to this question is option number C, between the thyropharyngeus and the cricopharyngeus muscle. Just revising once the important points about Zenker's diverticulum, because again a very important point from surgery. Zenker's diverticulum is one of the hotshot favorite topics. Just like achalasia, Zenkus is also a hotshot favorite topic of surgery, and it also overlaps with ENT, so I thought to discuss it over here. Okay, so Zenkus diverticulum means what? So it is just a outpouching of the esophagus, right? Diverticulum means outpouching of the mucosa. In case of Zenkus, it is outpouching of the esophagus. Zenkus diverticulum is common in which age group? Zenkus diverticulum is common in elderly. So please remember, it is most common in elderly. Okay, it is more common in elderly. What is Zenkus diverticulum? So please remember, this is how your pharynx looks like. Okay, so this is your external appearance of the pharynx. Okay, this pharynx usually has these pharyngeal constrictor muscles. The uppermost is your superior constrictor muscle. Then you have your middle constrictor muscle. Okay, this one is your middle constrictor, these ones are your superior constrictor, and then you have a inferior constrictor muscle. But this inferior constrictor muscle, it is made up of two fibers. Okay, these oblique fibers, these are known as thyropharyngeus. These oblique fibers, these are known as thyropharyngeus fibers, whereas these circular fibers that you can see, these are known as your cricopharyngeus. Circular fibers are known as cricopharyngeus. So inferior constrictor muscle of pharynx is made up of two fibers, oblique thyropharyngeus, circular cricopharyngeus, and in between them you can see a area, this triangular area. Okay, this triangular area, it is a weak area because muscle fibers are not present over here. So this weak area is actually known as Killian's dehiscence. This weak area is known as Killian's dehiscence. Dehiscence means weak, important that you need to remember. Okay, so you can remember it easily then. So this is the weakest area because muscle fibers are not properly present over there, right? Killian's dehiscence. So this Killian's dehiscence is the most common site for your Zenkus diverticulum to occur. But why Zenkus diverticulum usually occurs? So please remember, whenever there is esophageal peristalsis going on, if this esophageal peristalsis, there is increased pressure in the esophagus, that can lead to protrusion of the esophagus. But it will not, the muscle fibers will not let the esophagus protrude out. But at one side, that is at the Killian's dehiscence, as the muscle fibers are weak, the esophagus can easily protrude out. And that is why Zenkus diverticulum occurs. Right? Most common site, as we had discussed, it is the Killian's dehiscence, which is between the thyropharyngeus and the cricopharyngeus fibers of the inferior constrictor muscle of pharynx. Okay, so the two important one-liners that you need to remember. Zenkus diverticulum is which type of diverticula? So please remember, it is a false diverticula because not all layers of the wall are present in Zenkus. Okay, so it is a false diverticula. And second, it is a pulsion diverticula. There are two types of diverticula, pulsion or traction. Traction when there is a pull from outside, and pulsion when there is increased pressure from inside. So whenever there is increased pressure from inside, and that is why there is protrusion, it is known as a pulsion type of diverticula. Investigation of choice would be, what is this? So this is your barium swallow. So on barium swallow you can see this outpouching. So that is what is your Zenkus diverticulum, right? Here also you can see this outpouching, that is your Zenkus, right? On lateral view, usually you can see it very clearly. So investigation of choice would be a barium swallow. Please remember, usually in surgery, barium swallow is the first line investigation, or it is limited to some signs, but it is the investigation of choice in cases of Zenkus diverticulum. Okay, and mostly a lateral view of neck is preferred. And the treatment would be what? So treatment can be a surgery, and this treatment usually would be diverticulopexy. Okay, diverticulopexy, that means fixation of the diverticula. It can be Dohlmann's operation. Okay, and third, if the diverticula is very much large in size, then it can be diverticulectomy. I have just revised it all together from surgery also. Okay, so it would be easier because it is a very important topic. Okay, diverticulopexy, fixation, Dohlmann's operation, or diverticulectomy, removal of the diverticula. I hope this is fine now. So now you can, you have got the answer. Question number 7 now. Yeah, the cricopharyngeal myotomy can be performed for a smaller diverticula. Question number 7 states, guys, a diagnosed case of chronic suppurative otitis media, that is CSOM, now complains of diplopia, that means double vision, and pain behind the eye. Pain behind eye is known as retroorbital pain. Pain behind eye is known as retroorbital pain. What is this entity known as? Anybody? I know this is going to happen. So please remember, this is a triad usually. Okay, so please remember, this is a triad that I have given to you. First is CSOM. Usually in chronic suppurative otitis media, there is ear discharge, right? There is ear discharge. The first feature would be ear discharge. Second, due to sixth cranial nerve involvement. Due to sixth cranial nerve involvement, that means your abducens nerve, if it is involved, it would lead to palsy of the lateral rectus muscle. We discussed in optha. So therefore, there would be diplopia. Okay, and last thing, as there is involvement of the fifth cranial nerve, that means your trigeminal nerve, there would be retroorbital pain. Okay, the ophthalmic division of trigeminal nerve would be involved, and that can lead to retroorbital pain or pain behind eye. So this is a triad where there is ear discharge due to CSOM. Now this chronic suppurative otitis media has involved, or the infection has spread to sixth nerve, leading to diplopia. It also spreads to the fifth cranial nerve, leading to retroorbital pain. And the triad of ear discharge, diplopia and retroorbital pain together is a feature of petrositis, which is a very common and important complication of CSOM. So please remember, petrositis is a complication of CSOM. That means infection of your petrous air cells. Okay, infection of your petrous air cells. And petrositis में which triad is seen? It is your Grady-Negos syndrome, option B. So this is a feature of Grady-Negos syndrome. I hope this is clear. Now all of you were confused with option A, that was your Grissinger sign. So this is what your Grissinger sign looks like, guys. What is Grissinger signs? So please remember, Grissinger signs is nothing but the edema over mastoid surface. Grissinger sign is nothing but a pitting type of edema rather. If you put fingers, there would be pitting sign. दिखता है तुम्हें. Okay, so this is a pitting type of edema over the mastoid surface, and this is what is known as your Grissinger sign. This is what is known as your Grissinger sign. Alright, so this is a Grissinger sign. And Grissinger sign, anybody, is a feature of? Grissinger sign is a feature of which disease? Grissinger sign, pitting edema over mastoid surface, is a feature of anybody? It is a feature of sigmoid sinus thrombosis. It is a feature of sigmoid sinus thrombosis. Lateral sinus thrombosis भी बोला जाता है इसको. So, okay. So a feature of sigmoid sinus thrombosis is Grissinger sign. Alright. Whereas let's discuss about the two important triads. So there are three important triads that you need to remember from ENT. Grady-Negos syndrome, which is seen in petrositis, that we have already discussed, ear discharge, diplopia, retroorbital pain. Okay. Whereas the next one is Trotter's triad. Please tell me, Trotter's triad is a feature of Trotter's triad is seen in. Please tell me, Trotter's triad is seen in which condition? Till that time, I'll tell you what Trotter's triad is. So Trotter's triad can be remembered with a mnemonic UPT, urine pregnancy test, right? So UPT के mnemonic से Trotter's triad can be remembered. Very good, very good, very good. So please remember, so Trotter's triad, U for unilateral conductive hearing loss. U for unilateral conductive hearing loss, important. Second, P for palatal palsy. P for palatal palsy, and this palatal palsy is due to 10th nerve involvement. Palatal palsy is due to 10th nerve involvement. And important last one, T is due to trigeminal pain. Okay, so distribution in the pain in the distribution of the trigeminal nerve, usually known as trigeminal neuralgia. Okay, it is actually not neuralgia directly, but yeah, pain in the distribution of the trigeminal nerve. It is known as temporoparietal pain or trigeminal neuralgia. Okay, so three features of Trotter's triad are U for unilateral conductive hearing loss, P for palatal palsy due to involvement of the 10th cranial nerve, that is the vagus nerve, and T for trigeminal neuralgia or temporoparietal pain due to involvement of the 5th cranial nerve, that is your trigeminal nerve. And very good, all of you. Trotter's triad is seen in cases of nasopharyngeal carcinoma. Trotter's triad is a feature of NPC, nasopharyngeal carcinoma. A very important question again. NPC will be discussed further, don't worry. Then discussing about the third triad of ENT, Samter's triad, which can be remembered as BAP. Okay, Samter's triad can be remembered as BAP, where B goes for bronchial asthma. B goes for bronchial asthma. A goes for allergy to aspirin, or for that matter allergy to any of the NSAIDs. Okay, allergy to aspirin, or for that matter any of the NSAIDs. And P goes for what? P goes for nasal polyps, mainly ethmoidal polyps. Mainly which polyps? Ethmoidal polyps. So please remember the three features of Samter's triad. B for bronchial asthma, A for allergy to aspirin, and P for ethmoidal nasal polyps. Very good. Okay, so just revise karte ek bari jaldi se. So triad of petrositis is known as Gradinigos syndrome, and the three features are ear discharge, diplopia, retroorbital pain. The tortoise triad is seen in nasopharyngeal carcinoma, and the mnemonic is UPT. U for unilateral CHL, P for palatal palsy, and T for temporoparietal pain or trigeminal neuralgia. Third triad, Samter's triad. Mnemonic is BAP. B for bronchial asthma, A for allergy to aspirin, and P for polyps. That means ethmoidal nasal polyps. I hope I have made pretty clear. Now moving further. Question number 8. Identify the manure performed in the following image. So what is this manure? It is a cyclical manure when the patient is changing the positions from one position to another, right? Applies, Dix Hallpike, Hemlick's, या Gutsman's manure. Anybody? Very good, very good, very good. So most of you are right. So very good. This is a manure which is used to treat what? It is used to treat BPPV. That means benign paroxysmal positional vertigo. Right, I'll tell you what is BPPV. So please remember how to differentiate actually. As we all know, in BPPV, Applies manure is used for treatment. Applies manure is used for treatment, whereas Dix Hallpike manure is used for diagnosis. Dix Hallpike manure is used for diagnosis. So D से diagnosis, D से doctor, D से Dix Hallpike, ऐसे याद रख लो. Because please remember, Dix Hallpike manure is a diagnostic manure of BPPV, and therefore a doctor is required. Okay, please remember, a doctor or an examiner is required to make you perform. Okay, Dix Hallpike manure. Whereas Applies manure is a manure for treatment of BPPV, and it is usually performed by the patient alone. Here we can see the patient alone is changing the position. Therefore, the answer to this question is option A, Applies manure. Okay, here the answer is option A, Applies manure. Let's first discuss about Gutsman, and then I'll move further. Gutsman's manure, guys, please remember, it is usually the manure used in cases of puberphonia. Gutsman's manure is used in cases of puberphonia, right? What is puberphonia? Puberphonia is a feminine or a high-pitched voice in males. Okay, a feminine voice or a high-pitched voice in males. This is actually known as puberphonia. Therefore, the manure that we use to treat, or the speech therapy that is performed in cases of puberphonia, would be Gutsman's manure. Okay, so how to remember? Puber, P for Purush, okay, and the other one is Andro, so A for Aurat. This is how I remember it. Okay, so please remember, puberphonia is feminine voice in males. On the other hand, androphonia is a masculine or a low pitch voice in females. Masculine voice in females is known as androphonia. So A for Aurat, A for androphonia, P for Purush, P for puberphonia. This is how I remember it. Okay, and the manure used for treating puberphonia is known as Gutsman's manure. You can remember it. Hey man, have some guts. Okay, so that is how we remember it. Okay, puber and androphonia. Apart from that, if a patient is not improved with this Gutsman's manure, then a type 3 thyroplasty can be performed. Okay, a type 3 thyroplasty is usually recommended as a surgery in puberphonia, and a type 4 thyroplasty is recommended as surgery in androphonia. Okay, I hope this is clear with everybody. Then let's move on to this. So please remember, this is the image where the patient is changing the position. Okay, here the patient is changing the position. Okay, the patient is made to sit, and then he's suddenly pulled back, turned to the head is turned towards one side, and then he's again made to sit. Then he's again pulled back suddenly, and the head this time is turned towards the other side. So the head would be turned towards both of the sides. But what are we trying to check in this condition? So when a person is suddenly pulled back and head is turned towards one side, we are actually checking for nystagmus. Okay, we are actually checking for nystagmus. So if nystagmus is present, we say BPPV would be present. Okay, that is benign paroxysmal positional vertigo. Okay, so please remember what leads to BPPV. By the way, BPPV, benign paroxysmal positional vertigo, is due to what? It is due to the otoconia or the otolith. All of you were right. Otoconia. Okay, this otoconia or otolith are nothing but calcium carbonate crystals. Okay, so these are calcium carbonate crystals which are usually present where? These are usually present in the vestibule. That means the utricle and saccule. I hope you are quite aware that the inner ear has a part known as vestibule in middle, which is made up of utricle and saccule. So these otoconia or otoliths, these calcium carbonate crystals are present in the vestibule, and once if they are free, okay, if they can travel to the semicircular canals, and whenever they travel to the semicircular canals, the patient experiences vertigo. The patient will experience vertigo or dizziness. Okay, so whenever a patient will change the position, it is mainly seen when a patient changes the position. Okay, so when you change your head position, then you will feel dizzy, or then you will feel like you are having a vertigo. I hope this is fine, because that is the time when your otoconia or otolith will move from vestibule to the semicircular canal. So this is what is BPPV, benign paroxysmal positional vertigo. I hope it is fine, or still it is lagging. I'm not sure. Just a minute. I try to see if now it is connected. I hope the connection is also good. I'm not sure what's the issue, but I hope we can overcome it. So here we were discussing about BPPV, guys, and please remember I have explained you what BPPV is now. So BPPV, for diagnostic purposes, we require Dix-Hallpike manure, which is performed with the help of a doctor. So this one, where you can see a doctor or an examiner helping the patient, this is a Dix-Hallpike manure. This is a Dix-Hallpike manure, where only the patient performs the manure. It is known as the Epistaxis manure. So this is your Epistaxis manure. I hope it is fine now. Right? Yeah, thank you. So now this one, the beneath the one given below, this is very good. This is one is your Hemlich's manure. Okay, this one is your Hemlich's manure. And as we are quite aware that Hemlich's manure is used in cases of choking. So whenever a food particle would be stuck, okay, in the esophagus or in the larynx, what will happen if a food particle is stuck in the larynx? The patient would not be able to speak anything. That is known as aphonia. Along with that, he can also experience some respiratory distress. This is known as choking. So in cases of choking, therefore we actually give a thrust from behind, and this thrust is given, usually a pressure is given on the epigastrium, okay, in an upward and a backward manner, and this is what is known as your Hemlich's manure. So this is a very commonly layman thing that everybody should actually know in cases of choking, right? Moving further to question number 9. Question number 9 states, a 50-year-old woman, Pushpa, has a history of foul-smelling, blood-stained ear discharge from ears now. Okay, from ears, important. She now complains of fever, headache, vomiting. On examination, neck rigidity is present. Very important punchline. What is the likely diagnosis? Everybody? So there is a elderly woman presenting to us with foul smelling, blood stained ear discharge, okay, from ears. From ears means definitely it is a chronic condition. Ear discharge can be usually seen in otitis media, okay. So otitis media, it can be seen in ASOM also, CSOM also, but as it is from ears, this is CSOM, right? But which type of CSOM? So we have two types of CSOM, that is safe and unsafe CSOM. So here they have directly given it is atticoantral only, that means an unsafe CSOM, right? So they have already given. So now they are actually asking us about the complication depending on her recent features. And what are her recent complaints? The recent complaints are fever, headache, vomiting, and neck rigidity on examination. And very good, all of you are Very good, very good. So all of you are right over here. These features, fever, headache, vomiting, and neck rigidity, are the cardinal features of meningitis. So the answer to this question would be option B. If we talk about CSOM, guys, an important question: chronic suppurative otitis media. Suppuration means pus formation. So wherever the term suppurative comes, that means it is a pus forming infection. Right? So chronic suppurative otitis media is also a pus forming infection of the middle ear. Right? CSOM. So CSOM usually it develops as a sequel. It usually is a sequel or a complication of ASOM. It is usually a sequel of ASOM, that is acute suppurative otitis media. But CSOM can be of two types. Either it can be a tubotympanic CSOM or it can be a atticoantral CSOM. Okay. So tubotympanic CSOM is also known as safe CSOM. Tubotympanic is also known as safe CSOM. Tubotympanic is also known as safe CSOM. Whereas atticoantral CSOM is known as unsafe CSOM. Atticoantral CSOM is known as unsafe CSOM. Important. So first of all, if we talk about safe CSOM or tubotympanic CSOM, important features that you need to remember to solve a question. First of all, see this otoscopic image. I hope all of you are quite aware with the otoscope. If you have not seen, once Google the image, or you can see it in FMGE snaps too. I have included it. Okay. So otoscopic image of this ear would be what? So please remember, here this one is the pearly white membrane that we can see. It is our tympanic membrane. But please remember, here the tympanic membrane has been ruptured. So here we can see tympanic membrane perforation. But please see that the tympanic membrane has perforated in the center. Okay, it has margins all around it. That means there is a central perforation. So important feature, in cases of tubotympanic or safe CSOM, there is a central perforation. Along with this, there would be pus discharge. Along with this, there would be pus discharge. But the pus discharge in cases of safe or tubotympanic CSOM would be mucopurulent only. Okay, it would be only mucopurulent discharge. Mucopurulent means only it contains pus. But on the other hand, if we see about atticoantral or unsafe CSOM, here also we can see a perforation. Okay, this perforation can vary. It can either be a central perforation or a marginal perforation. Okay, but more commonly it is a marginal perforation. More commonly in unsafe, we can see a marginal perforation. Along with that, we can see pus. But pus discharge in cases of atticoantral or unsafe, it is usually scanty. Here it is excess in amount. Excess of pus discharge is seen in safe. But here the pus discharge is scanty. But important features to be remembered, guys. The pus discharge in unsafe CSOM, it would be blood stained. Due to granuloma formation, it would be blood stained, and important, it would be foul smelling too. And it is foul smelling due to a reason because it causes bone erosion. Okay, so in unsafe or atticoantral CSOM, there is bone erosion and there is granuloma formation. Therefore, there is a pus discharge which is scanty, blood stained, and foul smelling. Whereas in cases of safe or tubotympanic CSOM, there would be only a mucopurulent pus discharge. I hope this is clear. This is an important feature. How to differentiate between ASOM and CSOM? So in ASOM, usually the duration would be shorter. There would be a very acute history of onset of infection, first thing. Second, if you look at otoscopic image, there would be a cartwheel appearance. I have not included it here, but you can see in the FMGE snaps. Okay, this is your tympanic membrane oval one. Here you can see a cartwheel appearance, okay, due to dilated capillaries, okay, and behind this intact tympanic membrane. In ASM, usually the tympanic membrane is intact. Perforation is not commonly seen, okay. Just a cartwheel appearance is seen due to dilated capillaries, and behind this tympanic membrane, you can see pus filled, okay. So there would be excess of pus behind this tympanic membrane, okay, along with cartwheel appearance. Excess of pus would be seen. I hope this is clear, but no perforation is commonly seen in ASM. I hope you have answered that question. Then, most common ossicle eroded, a question one-liner that can come. This had come earlier also. Most common ossicle eroded. Now, in middle ear, we have 3 ear ossicles: malleus, incus, and stapes. Right? Largest one being malleus, shortest one being stapes. Stapes is rather the shortest bone inside the body. Okay? The smallest bone inside the body is stapes. And smallest muscle inside the body is stapedius muscle, which is attached to it. So most common ossicle eroded in this condition would be incus, and there is a reason behind it. Why incus is the most commonly eroded bone? Because it has no muscle attachment to it, and as there are no muscle attachment to incus, there would be decreased blood supply to incus. Therefore, it is more prone for erosion. I hope this is clear. Okay. In treatment of CSOM, guys, usually in CSOM, we usually perform myringoplasty. That means plasty means reconstruction. So here we reconstruct the myring. And what is myring? Myring is nothing but the tympanic membrane. Right? Myring is what? Myring is the tympanic membrane or your eardrum. So here we perform the reconstruction of tympanic membrane, that is myringoplasty. And myringoplasty mein, this is again a one-liner, which is the most commonly used graft. And this I need an answer from you. Which is the most commonly used graft in cases of myringoplasty? An important question, guys. Okay, and that graft is usually placed by the underlay technique. Okay, that graft is usually placed by a underlay technique. Apart from myringoplasty, usually we also perform tympanoplasty. Okay, we also perform tympanoplasty. So in tympanoplasty, usually we use the grafts. Okay, in myringoplasty, say better, we use the grafts in cases of tympanoplasty when we actually repair the whole tympanic membrane. Right? So myringoplasty or tympanoplasty can be performed, and the most commonly used graft for tympanoplasty would be anybody. Very good. It is the temporalis fascia. It is the temporalis fascia, not the muscle. Okay, it is the fascia. Temporalis fascia is the most commonly used graft. Okay, temporalis fascia is the most commonly used graft for these surgeries of tympanoplasty. I hope this is clear. The technique is underlay technique. Right. Along with that, you can also implant the prosthesis, and this procedure would be either known as PORP or TORP, that is partial ossicular replacement prosthesis or total ossicular replacement prosthesis. Okay, so please remember, usually silastic, that is a medical plastic which is used. So silastic ossicles are usually implanted instead of the real ossicles, because these real ossicles would be eroded, right? And that is the reason why we can replace this ossicles also, the ear ossicles. I hope this is fine. Now, what is the most common cause of atticoantral or unsafe CSOM? So here we can find the most common cause of atticoantral CSOM is usually this whitish material that has been accumulated. And this whitish material that has been accumulated, it is an important question. This is cholesteatoma. Most important cause of unsafe CSOM is cholesteatoma. Most important cause of unsafe CSOM is cholesteatoma. Okay, cholesteatoma. And cholesteatoma, here there is a tympanic membrane which has undergone rupture, most commonly marginal rupture. But please remember, above the tympanic membrane we can see a pocket, right? And this pocket is actually known as a retraction pocket. So usually in cases of unsafe CSOM, retraction pockets are formed. Okay, and in these retraction pockets, there is accumulation of this whitish material known as cholesteatoma, which is the most common cause of unsafe or atticoantral CSOM. The most common site for atticoantral CSOM, again a one-liner. The most common site for atticoantral CSOM is the Prosac space. Most common site for, very good other, it is the Prosac space. Okay, it is the space in the epitympanum. I hope you know the middle ear is divided into three parts: epi, meso and hypotympanum. So epi is the uppermost part. So in epitympanum there is a space between the neck of the malleus and the tympanic membrane that is known as the Prosac space, which is the most common site of cholesteatoma. Most common site of cholesteatoma is Prosac space. Okay, cholesteatoma is usually formed in the retraction pockets. And what is the treatment? So treatment in cases of atticoantral CSOM is usually it is a tympanoplasty. Okay, in cases of atticoantral CSOM, it is usually a tympanoplasty, but here we usually prefer doing a tympanomastoid exploration. Here we usually prefer doing a tympanomastoid exploration, because mastoid bone is also commonly involved in cases of unsafe CSOM. As I've told you, there would be bone erosion in cases of unsafe, so there it is better to perform a tympanomastoid CSOM, tympanomastoid exploration in cases of unsafe CSOM. Sorry. I hope this is fine. Now, most common extracranial complication if they ask you. So please remember, the most common extracranial complication of CSOM would be mastoiditis. Most common extracranial complication of CSOM is Mastoiditis. Most common extracranial complication is mastoiditis. But most common intracranial complication is meningitis. Most common intracranial complication is meningitis. Important. Okay. And that is what was our question. That means mastoiditis or meningitis could be seen commonly. But in this question, as you all seen, there was cardinal features of fever, headache, vomiting, and neck rigidity. Okay, these are classical findings of meningitis, and this neck rigidity is due to irritation of the meninges. I hope whenever we try to extend the neck, there would be irritation of meninges, which leads to the excessive pain. Okay, so there would be pain also on neck rigidity. Along with neck rigidity. This is a classical feature of meningitis. In mastoiditis, usually there would be inflammation of the mastoid area. There would be ironing of the mastoid surface, which we'll discuss further. Okay, we'll discuss about mastoiditis, don't worry. Sigmoid sinus thrombosis, this would have more commonly presented with a fever in spikes. Okay, so there would be spikes of fever. And this spikes of fever, it is actually known as a spiky fever known as picket fence fever. Sigmoid sinus thrombosis usually presents with picket fence fever. It is important. Okay, sigmoid sinus thrombosis commonly presents with picket fence fever. Along with that, there would have been a pitting edema over the mastoid surface that we discussed earlier. You saw the image, and that was Grisenger's sign. It would also there would also be a presence of Grisenger's sign. So these two features would have been commonly seen in SST, right? And there was a question on brain abscess, guys, in this recent INI-CET November 2021. They had given just a feature of CSOM again, okay, just a picture of CSOM. Here you can see, again, they had given the similar picture, a foul-smelling, blood-stained ear discharge, okay. A blood-stained ear discharge, foul-smelling, that means it is an unsafe CSOM or an atticoantral CSOM, right? So it was an atticoantral CSOM, but they had given a CT image of the brain, and in CT image of the brain, usually, there was air fluid level or abscess over here. An abscess in this area. They had asked what is this, which is the complication seen in the given CT image, and the complication was temporal abscess, right? I hope I have made very clear with this, because CSM and ASM are important topics. Now moving further to question number 10, guys. A patient was diagnosed with otosclerosis. So diagnosis is already given in the question, and following finding is seen on otoscopy. So this is the image, this is the finding seen on otoscopy. The arrow is also marked. Sorry, the arrow is also marked. Treatment of choice in this condition would be. So can anybody tell me what is this sign seen on otoscopy? This sign seen on otoscopy in cases of otosclerosis would be known as, you can see a pinkish U on the tympanic membrane, and this pinkish U on tympanic membrane is due to anybody? So please remember, this is known as your flamingo pink appearance. This is known as your flamingo pink appearance. Okay, this is known as your flamingo pink appearance. Very good, Komal. It is Schwartz sign. Okay, this is known as your flamingo pink appearance, also known as your Schwartz sign. Also known as your Schwartz sign. And flamingo pink appearance or Schwartz sign is not seen in all cases of otosclerosis. It is rather only seen in 10% cases of otosclerosis, and it is a feature of early otosclerosis. Okay, in early stages of otosclerosis, the patient will develop this flamingo pink appearance behind the tympanic membrane. Okay, this flamingo pink appearance is also known as the Schwartz sign. And the treatment of choice in early stages of otosclerosis, when Schwartz sign is positive. So whenever Schwartz sign is positive, the treatment of choice would be option D, sodium fluoride. So oral sodium fluoride is usually given in cases of early stages of otosclerosis. What was the treatment of choice in otosclerosis overall? I'm not asking about early stages or Schwartz sign positive patients. If the patient is not Schwartz sign positive, the treatment of choice would have been stepedotomy. I hope you remember this. It would have been stepedotomy. Yes, it is the active phase of the disease, acute phase of the disease. So overall, if I ask the treatment of choice overall, then the answer would have been stepedotomy. Okay, stepedotomy, with better answer would be Stepes piston prosthesis. Better answer would have been Stepes piston prosthesis, because the Stepes bone usually acts like a piston. Okay, just like a piston which behaves in an engine. So stepedotomy would have been the answer, followed by stapedectomy, And hearing aid can also be given in otosclerosis patient if the patient is unwilling for surgery. If the patient does not want a surgery, then you can give a hearing aid. But in flamingo pink appearance or short sign positive patients, sodium fluoride is the treatment of choice. Moving further to question number 11. Now, an 18-year-old boy came to OPD after he was slapped by his teacher. Otoscopy reveals tympanic membrane rupture. This is the image. Here you can find a tympanic membrane rupture. What is the most appropriate management? So please remember, it is just a tympanic membrane rupture, rather a traumatic tympanic membrane rupture. Okay, it is not due to some infection. Here the arrow that is marked, it is actually the bone that you can see behind which is shining. It is not any pus, because if it would have been an infection, guys, please remember, there would have been signs of inflammation like redness vagara that there would have been, okay, or edema in the mucosa would have been seen. Here the ear auditory canal is completely alright. There is no inflammatory signs. Okay, in the last question, if you're asking, stepedotomy is a better option, choice to be performed rather than stapedectomy, because if you remove everything, okay, if you remove all the stapes, it is harder actually to replace all the ossicles, because if we do a stapedectomy, we need to replace all the ossicles usually. Okay, either we need to perform a PORP surgery or a TORP surgery in that matter then. Right, whereas only the footplate of the stapes is affected. So we have a very specific approach only. We only actually try to repair that part which is undergone sclerosis. I hope I have answered it. So this was a question in August 2020 FMGE, guys. So 18-year-old boy presenting to OPD, slapped by his teacher, everything is fine. Otoscopy reveals tympanic membrane rupture. Here you can find a central tympanic membrane rupture. Therefore, it is likely to be traumatic. Second, most appropriate, then it is no signs of inflammation are seen. So definitely it is only a traumatic rupture. And in cases of tympanic membrane rupture, the treatment would be option A, conservative management. Okay, most of us marked it wrong in the August exam. So you don't dare to mark it wrong, guys. Please remember, there is only a conservative management because the tympanic membrane would repair itself eventually. Okay, so only a conservative management is required in these cases, right? Myringotomy with grommet insertion is a surgery used in cases of anybody? Myringotomy with grommet insertion is a surgery used in cases of, an important question though. Immediate myringotomy should not be performed anyways. And myringotomy is opening of the tympanic membrane which is already done. It is already perforated. Anybody? Myringotomy with grommet insertion? This is a very important question, guys. We have a question like this ahead. Myringotomy with grommet insertion is performed in? Very good, very good. Yes, it is the surgery of choice in cases of grew ear, also known as secretory or serous otitis media. Okay, so it is the treatment of choice. And this question has been asked: treatment of choice for grew ear or serous otitis media, and the answer was myringotomy with grommet insertion. Okay, moving further. Question number 12, guys. Now, I think that the image that was given in the paper was a wrong one. Okay, that was another image of a handkerchief test that was given. I did not check the PPT because actually I did not check the PDF that was edited by someone else. So, like, I did not get the time. I was in hospital. So, yeah. Usually it takes over months. Okay, it usually takes over months, more than like 3 to 6 months. It's the minimum time at least it takes. More than that only. So anybody, they have asked in this question, identify the structure 4 in the nasal endoscopy. So just like the similar image was given in August exam again, and these images have been asked repetitively, a nasal endoscopic image. Okay, so this is a posterior nasal endoscopy, right? Here they have asked the structure number 4. What is the structure number 4? First of all, this is the posterior nasopharynx. All of you have got this, right? Because all the options are resembling to posterior nasopharynx, right? Very good. So this one is what? This is your posterior nasopharyngeal wall. This is your posterior nasopharyngeal wall. Structure number 1. Structure number 2 is what? Here you can see it is a fossa. Okay, I have thing that most of you were confused. So please remember, the posterior most aspect, the posterior superior part of the nasopharynx would be a fossa of Rosenmuller. Please remember, the posterior superior part, the posterior most part would be your fossa of Rosenmuller. Whereas this is the opening. Here you can see a connection. Okay, structure 4 is actually a connection between the nasopharynx and the middle ear. Okay, it connects to the middle ear. It is responsible for ventilation of the middle ear. And this tube which connects from the nasopharynx till the middle ear and responsible for ventilation of middle ear is nothing else but the Eustachian tube. Therefore, structure number 4 is actually the Eustachian tube opening. And the Eustachian tube opening and the fossa of Rosenmuller both are separated by this. And what is this structure? This structure is known as torus tuberous. This structure is known as torus tuberous or the tonsillar pillar. Okay, I hope this is fine. So here also you can see the fossa of Rosenmuller clearly, right, on the very posterior superior most aspect of the nasopharynx. Okay, so it is behind the torus tuberous. If you need a landmark, it is behind the torus tuberous. Okay, adenoids are not usually seen in this image. Please remember, adenoids usually disappear by 6 years of age. Adenoids are actually lymphoid tissue aggregates. They disappear by 6 years of age. These are usually present in children. And adenoid hypertrophy is commonly seen in children. Okay, I hope everything is clear. And fossa of Rosenmuller, as we have already know now, fossa of Rosenmuller is the most common site for nasopharyngeal carcinoma. Fossa of Rosenmuller is the most common site for nasopharyngeal carcinoma. I hope everything is fine. All the structures you know now, right? And this is the structure number 5 is the posterior most aspect of your tongue. No, sorry, posterior most aspect of your inferior turbinate. Sorry. I hope everything is fine now. Moving further. Question number 13. An interesting question though. A patient sustained a road traffic accident, RTA, and had an anterior cranial fossa fracture with continuous nasal watery discharge. Handkerchief test finding is given in the image. So this was the finding that was given in the last question. So this finding is for this particular question, question number 13. So handkerchief test finding is given in this image. All the statements of this condition are true except. So first of all, except. So you need to mark a wrong statement. So we need to find a wrong statement. So all the given statements are true except, that means we need to find a wrong statement. So first of all, let's come to a provisional diagnosis first. Kya hai provisional diagnosis? So a patient sustained RTA, road traffic accident, had an anterior cranial fossa fracture and presented with continuous nasal watery discharge. Watery discharge cannot be mucus, it cannot be sputum, it cannot be any nasal discharge due to infection because it would be thickened, right? Mucus discharge is usually thickened. So it is a watery discharge. So watery discharge is usually due to CSF, right? So here CSF is continuously discharging from the nose and this is known as CSF rhinorrhea. This is known as CSF rhinorrhea, which is a feature of anterior cranial fossa fracture. CSF rhinorrhea is usually a feature of anterior cranial fossa fracture. But let's confirm our diagnosis further. Handkerchief test is given in the image. So usually in cases of CSF rhinorrhea, we perform a handkerchief test, okay? And when 2 or 3 drops of this CSF fall on the handkerchief, we let it dry and then we find this appearance. And this appearance is actually known as the halo sign. This appearance is actually known as the halo sign, or we also can say it as the target sign, where we can see yes, very good, halo sign or the target sign, where we can see alternate or concentric dark and pale rings. Okay, so these dark and pale rings, these are not due to CSF rhinorrhea. These are mainly due to traumatic CSF rhinorrhea. Okay, important thing that you need to remember. Halo sign is a feature of traumatic CSF rhinorrhea. That means blood is mixed with the CSF. If there would have only been CSF, this halo sign or target sign would not have been seen. Only CSF rhinorrhea does not lead to formation of halo or target sign. Only if blood is mixed with the CSF, then it would lead to formation of this halo or target sign. So halo or target sign is a feature of traumatic CSF rhinorrhea. And as here there was an anterior cranial fossa fracture, there was a traumatic CSF rhinorrhea, further confirmed by a halo or a target sign on handkerchief test. Let's go to the statements now. Which of the following statement is true about this condition and which of them is false? Option A says immediate endoscopic closure of leakage site is done? Do we perform an immediate endoscopic closure? Anybody? Till you answer the first question that I have, I'll go on to the statement number 2. Statement 2 says option B, beta 2 transferrin is helpful in diagnosis. Yes, presence of beta 2 transferrin in this fluid is diagnostic of CSF. Okay, so please remember, we send this sample for biochemistry lab, and if we can find presence of beta 2 transferrin, they say yes, this is CSF, and therefore this is the case of CSF rhinorrhea. So beta 2 transferrin levels would be helpful in diagnosis. Next, option C says HRCT skull is the preferred investigation. Yes, okay, the best investigation or the best radiological investigation that we have would be a high resolution CT skull. Okay, because the HRCT skull will actually help us identify the leakage site. It will actually help us identify the leakage site. Okay, and most commonly the leakage site is, that is option B. Option D, that is cribriform plate. So the cribriform plate of the ethmoid bone, it is the most common site of leakage in cases of CSF rhinorrhea. Okay, so cribriform plate is the most common site of leakage in CSF rhinorrhea. So statements B, C and D are right, and statement A, that is immediate endoscopic surgical closure of leakage site, is not done. Therefore the answer to this question is option A. Because in CSF rhinorrhea, guys, the treatment of choice would be conservative management. Okay, the treatment of choice would be conservative management. You manage the patient conservatively. Okay, you will treat the patient, you will give some antibiotics also to prevent any further bacterial infection. Okay, there is no specific drug as such. Yeah, you will just do a conservative management. Very good. Question number 14 now. Question number 14 says a female patient presents to ENT OPD with complaints of nasal obstruction, nasal discharge and loss of smell. On examination, nose is filled with crusts and a foul smelling discharge is present. She is found to have merciful anosmia, a very characteristic punchline. Everything is given in the question. So now they are asking what is the treatment of choice. Okay, so last line is what is the treatment of choice. So we need to come to a diagnosis first, and then we can talk about the treatment. So here it is a female patient presenting to OPD with complaints of nasal obstruction, nasal discharge, loss of sense of smell, and loss of sense of smell is known as anosmia, right? On examination, nose is filled with crust. Okay, so and these nose is filled with crust and there is foul smelling discharge, but the patient is having merciful anosmia. What do we mean by merciful anosmia? Though her nasal discharge is giving a very bad smell, there is a foul smelling nasal discharge. Okay, that can be sensed by you, but the female is having anosmia herself. Okay, the female could not sense the smell of her own. Therefore, it is known as merciful anosmia. Okay, so this is merciful anosmia on nasal discharge, nasal obstruction, and nose filled with crust is a very characteristic feature of atrophic rhinitis. Very good. It is a very characteristic feature of atrophic rhinitis. Atrophic rhinitis is also known as ozena, or atrophic rhinitis is also known as ozena. Atrophic rhinitis is actually due to atrophy of the mucosa, submucosa, as well as the bones of the nasal cavity. Okay, mucosa, submucosa, as well as the bones of nasal cavity. Everything is atrophied. Okay, and as everything is atrophied, therefore there would be wide roomy nasal cavities. There would be wide roomy spacious nasal cavity, and this was a question in ionized heat in November 2021. Some this was a clinical case which was given, and they had given what is the finding that we will see in this patient, and one of the options was roomy nasal cavities. Okay, so we will find wide roomy nasal cavities as everything is atrophied. Okay, and as there is presence of these wide roomy nasal cavities, therefore there would be excess mucus production, and this excess mucus production would lead to it will undergo drying, and this dried mucus would lead to crust formation. So excess of crust, the nasal cavity would be filled with crusts. Okay, and along with crust there would be a foul smelling discharge, but the patient is anosmic herself, therefore the patient could not smell her discharge herself, therefore it is known as merciful anosmia. So merciful anosmia is a very characteristic feature of atrophic rhinitis or ozena, and the most common age group, it is most commonly affects usually females. So please remember, it most commonly affects Females, very good. Adult females mainly. Yeah, the most common cause would be in among organisms if they ask. Yes, it is Klebsiella ozynae. But it can be also caused by many other conditions like some drugs vagara. So atrophic rhinitis can be caused due to multiple conditions. And the most common organism causing it is Klebsiella ozynae. Therefore, it is known as ozina. Okay, on examination, we'll find wide roomy nasal cavity, excess of crust in nasal cavity, and a foul smelling discharge. The treatment of choice, anybody would be? What is the answer? I hope most of you would have answered it. What is the treatment of choice? Now coming to the answer. Now we had a diagnosis already. The answer to this question would be option A. The treatment of choice would be alkaline nasal douching. Okay, you actually prepare a solution of sodium bicarbonate usually or baking soda vagara. Okay, and that sodium bicarbonate solution you fill it in syringe and then you push it in your nose. Okay, so it is told to the female only. The female is taught how to do it. Okay, and that is known as alkaline nasal douching. Okay, that's alkaline nasal douching is usually the treatment of choice in cases of atrophic rhinitis. Why? Because please remember, surgery is not the ultimate option usually. Okay, so surgery is not the ultimate option. The patient can again present to you with multiple other conditions, or maybe most of the patients are not even willing for surgery. Therefore, it is a very easy option, that is alkaline nasal douching with sodium bicarb. If they ask you about the surgery, then what is the surgery? Very good, most of you have answered it. It is the modified Young's operation. Okay, the surgery of choice would be modified Young's operation. Young's operation, previously it was performed. Young surgery mein what we used to do? We used to close one nasal cavity for 6 months and then we used to again do the same thing with the other nasal cavity. Right? So alternate, we used to close both the nasal cavities. This was known as Young's operation. Then we came up with a newer surgery known as modified Young's operation, where we actually do a partial closure of both the nasal cavities. Okay, a partial closure of both the nasal cavities is done, and this is known as modified Young's operation. That would be the surgery of choice in cases of atrophic rhinitis. Septoplasty, it is usually performed for DNS, that is deviated nasal septum. And tetracycline plus streptomycin is usually a drug of choice for rhinosporidiosis or woody nose. We'll discuss it further. I've explained it, right? No issues with this now. Moving further. Question number 15. This was a question of FMGE June 2020. June 2021. Which of the following is an unpaired cartilage of larynx? So if you are in a dilemma that our anatomy basic questions are from ENT or any of the clinical subjects, so please remember clinical subjects में से भी basic questions पूछे जाते हैं. Okay. So which of the following is an unpaired cartilage of larynx? Very good. The answer to this question is option B, thyroid. So if we talk about laryngeal cartilages, how many laryngeal cartilages do we have? We have in total 6 laryngeal cartilages, out of which 3 are unpaired and 3 are paired. The 3 unpaired laryngeal cartilages are known as, first is your thyroid cartilage, which is the largest one. Next is your epiglottis. Okay, next is your epiglottis, which is a leaf-like cartilage. And third important one is your cricoid cartilage, which is a ring-like cartilage, cricoid cartilage. These 3 are unpaired. Okay, so which 3 laryngeal cartilages are unpaired? Thyroid, epiglottis and cricoid. Thyroid, epiglottis and cricoid. Whereas the paired laryngeal cartilages would be arytenoid cartilage, corniculate cartilage and cuneiform cartilage. Corniculate and cuneiform cartilage. Out of these, corniculate and cuneiform, these do not have any functional value. These are considered rudimentary. Okay? This is fine. An important one-liner that you need to remember, this was also a question in previous exam. Cartilage which does not ossify or does not calcify with age. The cartilage which does not ossify or calcify with age is actually the epiglottis cartilage. It is the epiglottis cartilage. Epi means upper, above, and glottis means your vocal cords. So the cartilage which covers the vocal cords and prevents aspiration, that is known as epiglottis. It is a leaf-like cartilage. Okay, it is a leaf-like cartilage and it is an elastic cartilage. Important, it is an elastic cartilage and therefore it does not ossify or calcify with age. Whereas the other cartilages, over a period of time, like more than 25 years, these cartilages would ossify or calcify. The thyroid, cricoid, every cartilage would ossify, okay, over a period of time. Important. I hope this is fine with everybody now. Epiglottis is the cartilage which does not ossify. Important question, very important. Moving further to question number 16, and this is a question जिसको हम क्या बोलते हैं, सरकारी. So this is a very important question, guys. Repeated multiple times. This can come in your examination also. In the last 3 to 4 sessions, it has been repeated twice or thrice. Okay. Everybody has solved this question many a times now. So, a 38-year-old trumpet player. Okay, for that matter, any wind blowing instrument अगर आता है, saxophone, trumpet, शहनाई, okay, कुछ भी हो, anything, any wind blowing instrument player, okay, trumpet player has developed a right-sided neck swelling in upper part of the neck. The swelling keeps changing on and off. The swelling keeps changing on and off. Okay. The X-ray neck has been given below. What is the possible diagnosis? So this is the AP view. This is the lateral view of the X-ray neck which has been given. Okay. So very easy. If a trumpet player present, or trumpet or any of the wind blowing instrument player presents to you with neck swelling, it is most likely laryngocele. आंखें बंद करके भी मार सकते हो, it is laryngocele because it is the most common thing. But don't do that way. Okay, always see the other features also given in the question. Okay, here they had said there is a right-sided neck swelling only on one side. So usually laryngocele commonly is unilateral. Okay, and this swelling keeps on changing on and off. Okay, that means it is an air-filled swelling, right? It is an air-filled swelling. Therefore, whenever air goes, it would swell. It is increase in size. Whenever air goes out, it will decrease in size. Okay, so the swelling keeps on changing the size. X-ray neck has given over here. You can see on the right side of the neck, you can see a air-filled cavity, air-filled sac, and that is what is a laryngocele, right? So the most probable diagnosis over here would be laryngocele, right? Here, if you press this swelling, okay, if you press this swelling from outside, there would be a hissing sound, okay, and this hissing sound on pressing this swelling will be due to the escape of air. Okay, whenever you press the neck swelling, there would be escape of air, and this escape of air will produce a hissing sound. It will produce a hissing sound, and this is known as the Brice sign. This is known as the Brice sign. Important one-liner. So Brice sign is a feature of laryngocele. Brice sign is a feature of laryngocele. Yeah, X-ray neck is usually taken with Valsalva maneuver. The patient is asked to fill up air, okay, and stop, and then we take a X-ray usually. Okay. This is fine. Okay, so how to differentiate the other features, guys? So it is important you need to differentiate other features too. So first of all, laryngocele is what? So please remember, laryngocele is actually the dilatation of saccule. Okay, laryngocele is actually a dilatation of saccule. Important. If they ask you the definition only, so kya karoge tab? Okay, it is a dilatation of saccule. So saccule is actually a structure of the ventricle. Okay, I hope you know this basic structure. These are your false vocal cords. These are your true vocal cords known as glottis. Okay, and these are your false vocal cords known as ventricular bands. In between these two, there is a space known as ventricle. So this space is known as the ventricle. And in this ventricle, there is outpouching known as saccule. There is outpouching of ventricle known as saccule. So when this saccule enlarges in size, it dilates, it fills with air, then it would turn into laryngocele. Then it will turn into laryngocele. Yes, abnormally dilated saccule. Very good. And saccule, important one-liner. Saccule is known as the oil can of larynx. Saccule is known as the oil can of larynx because it contains maximum mucous glands. So maximum mucous glands are present in saccule, therefore it is known as oil can of larynx. How to differentiate others? So just see, it is important from surgery point of view, so I am telling you. Thyroglossal cyst, okay, thyroglossal cyst is a congenital anomaly of the thyroid. It usually presents with a midline neck swelling. Okay, it usually presents with a midline neck swelling. So it is not on one side, it is a midline neck swelling, important. And this midline neck swelling would move with deglutition or swallowing. So whenever a patient will swallow, there would be movement of this thyroglossal cyst above or below. Okay, so this is known as a thyroglossal cyst, which is treated by a surgery known as cyst trunks operation. Important one-liner. Then branchial cyst, usually it is also neck swelling, but it is usually unilateral. Okay, it is a brachial cyst is a neck swelling. It is unilateral, but it is anterolateral. Okay, it is anterolateral. That means it is just anterior to the sternocleidomastoid muscle. Branchial cyst is actually a congenital anomaly. It is due to delayed closure or non-closure of the brachial pouches. Okay, so if the brachial pouches do not close, therefore there would be a neck swelling known as branchial cyst. It is a cystic swelling on the anterolateral neck over here somewhere. Okay, whereas cystic hygroma, okay, it is usually seen in children. It can be congenital, it can be acquired cystic hygroma, but it is a posterolateral neck swelling. It is a posterolateral neck swelling. So it is seen in the posterior triangle of the neck, somewhere over here. Okay, and cystic hygroma would be trans illumination positive. Whenever you pass a light, as there is only fluid inside it, it would be trans illumination positive. Okay, so trans illumination would be positive in cases of cystic hygroma, and cystic hygroma is actually a cyst formation with the lymphatic fluid. There is some abnormality in the lymphatic system. I hope this is clear. Now you know the differential diagnosis. Moving further, question number 17. A patient was suffering from nasal discharge, nasal blockage, and a postnasal dripping. A X-ray Waters view has been ordered, which is given in the image below. What is the likely diagnosis? I hope it was very easy for all of you now. Patient suffering from nasal discharge, nasal blockage or obstruction, and a postnasal drip. Okay, these are usually features of sinusitis, and anyways all the options in the question were sinusitis only, so these are features of sinusitis. X-ray Waters view has been ordered. So here you can see this is the occipitomental view. Okay, from mentum we have taken the X-ray, so this is the occipitomental view known as the Waters view, and this was the image which came in FMGE June 2021. This was the Waters view. Here it is usually taken for maxillary sinus, ethmoid sinus, and the frontal sinus. Okay, whereas if the patient is asked to keep the mouth open, if the patient keeps the mouth open, then we can also visualize the sphenoid sinus, just like in this image. Okay, we can also visualize the sphenoid sinus. Okay, so that is the Waters view. So in Waters view, here we can see they have marked what they have marked. This is with sinus. First of all, the cheekbone contains which sinus? It contains the maxillary sinus. Okay, so it becomes very easy. And here you can see a air fluid level, right? So here you can see some pus, okay, or some fluid, and here you can see air in this. Okay, so air appears black, so the air is above and the fluid is below. So air fluid level is present. Okay, in cases of sinusitis, there would be a air fluid level on an X-ray that would be seen. Important feature: air fluid level is present. Right, and as the maxillary sinus affected, therefore it is option B, maxillary sinusitis. Development of sinuses, yaad rakho yaar, the sequence is important. They can ask you from anatomy. So the development of sinuses goes this way. Okay, first develops the maxillary sinus, second the ethmoid sinus, third the sphenoid sinus, and last the frontal sinus. Okay, both of these sinuses, they are present at birth, maxillary and ethmoid. Okay, both of these sinuses are present at birth. But ethmoid is the most developed sinus at birth. If we talk about birth, so ethmoid is the most developed sinus at birth. I hope this is clear with everybody. At least remember this. Okay. And we have discussed frontal sinusitis was associated with osteomas, a benign bone tumor. Okay, osteomas, and the Pott's puffy tumor. Right? Important. Ethmoidal sinusitis is common in children. Ethmoidal sinusitis is common in children. Moving further, this is the Waters view. This is the Caldwell's view. First of all, this is the occipitofrontal view. Okay, it is taken from straight, right? So this is the occipitofrontal view. And occipitofrontal view of all the paranasal sinuses is known as the Caldwell's view. And Caldwell's view pe we can visualize the frontal sinus, the maxillary sinus, the sphenoid sinus, and also the ethmoid sinus. So every sinus is visualized properly. Sphenoid sinus is not visualized properly over here because there is an overlap. So in Caldwell's, we can visualize three important sinuses. That is the frontal sinus over here in two frontal bones. Then the ethmoid sinus over here. Then the maxillary sinus in the cheekbones. Okay, here we can also visualize the mastoiditis. Okay, and for sphenoid sinus, we usually take a lateral X-ray of skull. For sphenoid sinus, we prefer to take a lateral skull X-ray. I hope it is clear. And this is where the patient's mouth is open, taken from an angle. This is known as the occipitomental view, and this occipitomental view of a paranasal sinuses in an X-ray is known as the Waters view that we saw right now. Right, it is a Waters view. I hope everything is clear. Moving further to next question, that is question number 18. Here they say, which of the following muscle is the abductor of the vocal cord? Which of the following muscle is the abductor of vocal cord? Anybody? I hope you are able to answer this. Which of the following muscle is the abductor of vocal cord? So there are laryngeal muscles. Okay, there are intrinsic muscles, there are extrinsic muscles. So extrinsic muscles usually would be used for movement of larynx above or below. Okay, like stylopharyngeus, thyropharyngeus, geniohyoid, all of these muscles. They are extrinsic. And intrinsic muscles, very good. So they are actually divided into three types. Those would be abductor muscles, which will open the glottis or the vocal cords. Okay, the one which opens the glottis or the vocal cord is known as the abductor muscle. And larynx has only one abductor muscle, and very good all of you, that is posterior cricoarytenoid. Okay, only one abductor is present in larynx. That muscle is posterior cricoarytenoid. Only one abductor in larynx, and that is posterior cricoarytenoid. Very good. Then it has four adductors, which would be responsible for adduction or closure of the vocal cords. I'm talking about vocal cords, not the laryngeal inlet. Please remember. Okay. So closure of glottis or vocal cords or adduction of vocal cords is done by four important muscles. Okay. The first one is cricothyroid muscle. Then we have interarytenoid muscle. Interarytenoid muscle between the two arytenoid cartilages. Then we have thyroarytenoid muscle. Okay, thyroarytenoid muscle and the lateral cricoarytenoid muscle. These are four adductors. So which was the abductor? Abductor was posterior cricoarytenoid. Adductors are four: cricothyroid, interarytenoid, thyroarytenoid, and lateral cricoarytenoid. And there are two tensor muscles which are responsible for quality of voice. Okay, so quality of voice would be determined by the tensor muscles, and these tensor muscles are the cricothyroid muscle. So cricothyroid is the main tensor of vocal cord. So please remember, the main tensor of vocal cord or the muscle responsible for quality of voice is cricothyroid muscle, and the other one is the vocalis muscle. Don't hesitate, vocalis is just a part of lateral cricoarytenoid. So some faculties might have given you lateral cricoarytenoid also. That's totally fine, I hope. Okay, so please remember, the main tensor of vocal cord, one liner, cricothyroid. Main tensor of vocal cord, cricothyroid. It is responsible for quality of voice. Only abductor, posterior cricoarytenoid. Important is to remember about the innervations of these. Motor innervation is important, at least if you remember about motor innervation. All muscles of larynx, okay, all intrinsic muscles of larynx are innervated by, all intrinsic muscles of larynx are supplied or innervated by, anybody, are innervated by the recurrent laryngeal nerve, RLN, except for one, except the one muscle, and that is cricothyroid, except the one, that is cricothyroid. So important, all muscles of larynx are innervated by recurrent laryngeal nerve except one, that is cricothyroid, and cricothyroid is innervated by the external branch of superior laryngeal nerve. Cricothyroid is innervated by the external branch of superior laryngeal nerve. I hope everybody is clear with this. There was one question that I need to tell you. So this is your thyroid gland, okay guys, and in relation, close relation to the thyroid gland, inferiorly we have two RLN nerves, okay, recurrent laryngeal nerve, and superiorly we have the SLN, that is the superior laryngeal nerve. So in cases of thyroid surgeries, there would be injury to one of these recurrent laryngeal nerve. Okay, in cases of thyroid surgery, iatrogenic case hota hai, there would be injury to this recurrent laryngeal nerve. This was a question, that's why I'm telling you. Injury to recurrent laryngeal nerve is most commonly caused in India due to removal of thyroid gland or during thyroid surgeries. Most common cause of RLN injury is thyroid surgeries. Okay, so iatrogenic cause hoti hai. I hope this is fine with everybody. So cricothyroid has two functions, adduction and tensor muscle above. Okay, it is innervated by external branch of superior laryngeal nerve. Moving further to question number 19, it states a 4-year-old child was brought to pediatric emergency with respiratory distress, fever, drooling of saliva and stridor. Child's SpO2 is dropping. What would be your immediate management? Okay, no X-ray was given in the question. This was the only question asked. 4-year-old child, that is of school going age, brought to emergency, respiratory distress, fever, drooling of saliva, noisy breathing, that means stridor, child's SpO2 is dropping due to respiratory distress, and what would be your immediate management? So what are you suspecting actually? So what are you suspecting in this case? What is the provisional diagnosis in this case? The provisional diagnosis in this case is a pediatric airway emergency. Okay, it is a pediatric airway emergency which is very common between 2 to 7 years of age, which is very common in 2 to 7 years of age. Okay, here the child is 4 years of age. The child presents with respiratory distress, fever, drooling of saliva, and this drooling of saliva is due to because the child is not able to swallow. Okay, because everything that he swallows is painful, therefore the saliva is not swallowed, rather there is drooling of saliva from mouth, and there is noisy breathing or stridor. More commonly it is the inspiratory stridor. Child's SpO2 is dropping. What would be your immediate management? So child's SpO2 is dropping due to respiratory distress. So the provisional diagnosis in this case, it is a toxic condition. Here the child would attain a tripod position. The child would be sitting bending forward. Okay, this can also be given in question. The child would be sitting in a tripod position. This is an acute airway emergency. Okay, here the provisional diagnosis would be acute epiglottitis. Here the diagnosis is acute epiglottitis. Okay, please remember this is a pediatric airway emergency. Very important question. Okay, this was a question which has been asked. Okay, if we see a lateral x-ray of neck, lateral x-ray soft tissue neck, if it is seen, so here they have marked the arrow. What is this? This is the thumb sign which is seen. Okay, it is due to enlarged epiglottis. A thumb sign is seen due to enlarged epiglottis. Okay, so this is inflammation of the epiglottis. It is the airway emergency. So please remember here, as there is drooling of saliva, because the everything that the child swallows is painful. It is because of the laryngeal edema. Okay, the laryngeal edema is there, and therefore anything he swallows would be very much painful. Okay, so as there is laryngeal edema, after a point of time, guys, intubation would also be difficult. Okay, and as this child's SpO2 is dropping already, we will require intubation. So the first step or the most important step in cases of acute epiglottitis would be option B, urgent intubation. The most important step in acute epiglottitis is urgent intubation or immediate intubation. Okay, that is early intubation is the treatment of choice in cases of acute epiglottitis. Once intubation is done, definitely you can order a X-ray lateral view of neck if it is available in your hospital, a portable X-ray. Otherwise, it's totally fine. You would start the treatment directly. Okay, injectable antibiotics are given, steroid therapy is started, everything is given. Okay, IV antibiotics are usually definitive treatment. Okay, and assessment of larynx by laryngoscopy, rather it is avoided because any painful stimulus to the child will rather precipitate the laryngeal edema. It will increase the laryngeal edema. So repetitively checking temperature, okay, or assessment of larynx by laryngoscopy, okay, these will rather precipitate laryngeal edema, and therefore they are to be avoided. So assessment of larynx is not done. X-ray lateral view of neck, it is not required in cases of emergency. Injectable antibiotics would be definitive treatment, but immediate management would definitely be urgent intubation. Okay, and a similar finding that you actually get confused with is acute LTB, that is acute laryngotracheobronchitis. Acute laryngotracheobronchitis, which is also known as CRAW. So acute laryngotracheobronchitis is also known as CRAW, and most common cause of acute LTB would be para-influenza virus. Most common cause of acute LTB would be para-influenza virus. I'll come to acute epiglottitis cause. Okay, so most common cause of acute LTB or CRAW would be para-influenza virus. The age it commonly affects is from 3 months to 3 years of age. In CRAW it is 3 months to 3 years. CRAW it is 3 months to 3 years, whereas in epiglottitis it is 2 to 7 years of age. Symptoms here, usually the child would again have respiratory distress, but the respiratory distress here would be mild. Okay, the respiratory distress in CRAW would be milder. There would be stridor, noisy breathing would be present, but the stridor in LTB usually is biphasic. It is present in inspiration also and expiration also. So a biphasic stridor would be there. A low grade fever would be present. Okay, it is not as much high as in epiglottitis. A low grade fever is present, and an important feature, a barking cough is present. Okay, very important. A barking cough is present. Okay, the cough feels like a child is barking, like a barking dog. Okay, And X-ray neck, if we take, we need to take a AP view. In epiglottitis, it was a lateral view. In laryngotracheobronchitis or Kraut, it is a AP view of the X-ray neck. Here we can find narrowing of the subglottis. Okay, acute laryngotracheobronchitis definitely can affect any part of the larynx, trachea or bronchi, but most commonly affected part is your subglottis. Most common affected part is your subglottis, and therefore we will find narrowing of the subglottis due to edema, and therefore it is known as which sign? This is known as a steeple sign. On X-ray neck we will find a steeple sign, just like the apex of a church which is known as a steeple. So just like that we will find this steeple sign. I hope I have made everything clear. And yeah, pencil tip sign or steeple sign. Now coming to acute epiglottitis, a controversy and a question had come in FMGE June 2021 session. Acute epiglottitis, they say, most of the books say the most common cause is HIB, Haemophilus influenzae B. But a more practical approach, I'll definitely take that one, because please remember, in India there is a mass vaccination for Haemophilus influenzae B, because HIV vaccine has already been included in the national immunization schedule, as all of us know, right? Therefore, like most of the journals say that the incidence of HIV in HIV epiglottitis have reduced. Okay, and the most common cause nowadays would be Streptococcus pneumoniae. Most common cause would be nowadays Streptococcus pneumoniae, because there has not been a vaccine for Streptococcus pneumoniae yet in the national immunization schedule. Therefore, children are actually not yet immunized for Streptococcus pneumoniae, rather they are immunized for HIV. Therefore HIV के chances कम हो गए हैं, Streptococcus pneumoniae के increase हो गए. If you go via books and many of the pediatricians, most of the pediatricians say that in clinical practice still we get most of the cases of HIV, but more practical approach is this one. Therefore I prefer Streptococcus pneumoniae. Okay, most of the faculties differ from their opinion, but I still prefer Streptococcus pneumoniae because it is a more practical and a logical based approach, I feel. Okay, with this I move further. Moving further to question number 20. Here they say a 3-month-old child was brought with inspiratory stridor which increases on crying. This is a very common question. Mother gives history that it is present almost since birth. So it is almost since birth, that means it is some congenital condition, right? It is present almost since birth. Indirect laryngoscopy picture is given below. This is the indirect laryngoscopy picture. I hope you will see the images from FMG snaps for indirect and direct laryngoscope, rhinoscope, otoscope, all of this. Okay. So indirect laryngoscope picture is given below. This is your epiglottis. But this epiglottis, rather than it is not leaf shaped now, it has attained a new shape, that is a omega shaped. So here we can find a omega shaped epiglottis. And omega shaped epiglottis, it is a feature of, everybody knows it, it is laryngomalacia. So the provisional diagnosis in this condition would be laryngomalacia. That means softening of the larynx. Laryngomalacia is a congenital condition, and important, it is the most common cause of stridor. It is the most common cause of stridor, congenital stridor we can say. Noisy breathing. Most common cause of stridor or noisy breathing during, like after birth, is usually laryngomalacia, in which on laryngoscopy we can find the omega shaped epiglottis. And what is the answer? Important, the stridor in cases of laryngomalacia is usually inspiratory. So it is a common cause of inspiratory stridor, and this inspiratory stridor, it increases on crying. Whenever a child cries, this inspiratory stridor would increase, and this inspiratory stridor would decrease on prone position. Whenever a child is turned into a prone position, ulta, okay, facing the floor, okay, in prone position usually the stridor will decrease. Okay, this is the important feature that would be given in the options. If image is also not given, you can just like diagnose it from the history itself. And what is the treatment of choice for this condition now? Laryngomalacia is the diagnosis, so treatment of choice is very good. This was a question which has been asked. The treatment of choice is option D, reassurance to the parents, because this is a self-limiting condition. No treatment is required. Reassurance because this is a self-limiting condition. Okay, CO2 laser excision, it is usually a treatment used for congenital laryngeal webs. Okay, CO2 laser excision is usually used for congenital laryngeal webs. Okay, and it is also used for papillomas. Okay, it is also used for polyps या papillomas जो होंगे ना, to remove those laryngeal polyps वगैरह, we also use the CO2 laser excision. Okay, I hope you are clear with this. Antibiotics and steroids are usually used in infective conditions like epiglottitis. Okay, moving further to question number 21. They say a 6-year-old child complains of hearing loss and sense of fullness in ear. Very important. 6-year-old child means a school age child. Okay, a school age child complaining of two important features, that is hearing loss and fullness in ear. Okay, fullness or heaviness in ear would be there. These two important findings in a school age child are most likely to be glue ear or serous otitis media, as all of us know, right? Now further, our diagnosis is confirmed. Okay, here we have made a diagnosis of glue ear, provisional one. Now let's confirm our diagnosis. They have performed a tympanometry. On tympanometry, it shows a type B curve. It is confirmed now. Type B curve is a flatter curve that we saw, or this one. Okay, it's the flatter curve, which is usually seen in conditions of glue ear or serous otitis media. Okay, in glue ear or serous otitis media. Important feature that you need to remember: flat curve or flat curve or type B curve. Apart from glue ear, it is also seen in cases of tympanic membrane perforation. It is also seen in cases of tympanic membrane perforation, because there is a conductive hearing loss in both these conditions, right? So conductive hearing loss would be seen in tympanic membrane perforation also, and in glue ear or serous otitis media also. Very good. So the answer to this condition would be option D, serous otitis media. And what is this surgery seen? This surgery, important one, where we have made a opening in the posterior inferior quadrant. Opening in the posterior inferior quadrant is made, and we have inserted some plastic material, okay, a silastic material. Very good, very good. It is a myringotomy. So we have made an opening in the myring, that is opening in the tympanic membrane. So it is known as myringotomy. Along with that, we have inserted some material known as the grommet. Okay, so grommet insertion is done. So this is the treatment of choice or the surgery of choice in cases of serous otitis media, secretory otitis media, also known as glue ear. Okay, when the ear is full with glue, okay, or wax, the middle ear is full with wax. Okay, usually seen in school children between 2 to 7 years of age group commonly. Okay, again, and type B or flat curve is seen. Moving further to question number 22. A very common question. Question asked in FMGE June 2021. A 42-year-old diabetic woman was tested positive for COVID-19, and she complains of nasal obstruction, headache, nasal discharge, blackish discoloration of the skin as given below. What is the diagnosis? So now they are asking us about the diagnosis, right? Important. What are the features? Adult female who is a diabetic tested for COVID positive. She now complains of nasal obstruction, headache, nasal discharge. Okay, so all of these features along with the skin discoloration, usually involving the nasal bridge at times, the skin over the cheek, the skin over the orbit, a blackish color discharge. It can also involve the nasal cavity. It can also involve the palate. Okay, so blackish spots can be seen in the nasal cavity or the palate also. Along with that, we can also find a blackish mass inside the nasal cavity. All of these features, they point towards a diagnosis of option C, mucormycosis. Yes, in COVID-19, as we have seen a surge in cases of mucormycosis post-COVID, and they were usually seen in diabetic patients or patients who are immunocompromised like HIV patients, right? Because in COVID, we were giving steroid therapy, right? High dose steroid therapy was given, and therefore the patient was becoming immunocompromised. In immunosuppressed patient, there is a high chance of infections, and therefore the most common infection which was spreading was mucormycosis. Okay, mucormycosis, it is a fungal infection in which there would be blackish discoloration of all the parts, and there was even removal of the orbit, the mandible, the maxilla. Okay, everything was removed in surgeries because everything would be damaged, and we need to remove it to spread the further to prevent the further spread of infection to the cranial cavity. I hope this is fine. Very good. All of you a step ahead. Very good. The drug of choice in cases of mucormycosis would be LAM, that is liposomal amphotericin B. Okay, liposomal amphotericin B. Along with debridement is there. Usually we remove all these structures. Maxilla, mandible, everything is removed. Okay, yeah, LAM plus debridement would be the treatment of choice. Drug of choice if asked, that is LAM, liposomal amphotericin B. Also, a azole derivative we discussed in pharma. We can also use the azole derivative like posaconazole, right? Posaconazole can be used. I hope this is fine. Allergic fungal sinusitis, it can also present with the same features, but no blackish discoloration of skin would be seen usually. Okay, there would be involvement of the sinuses, vagara. There would be nasal blockage, nasal discharge, everything. Headache can be there, but no blackish discoloration as such. Antrochoanal polyp is actually known as the Killian's polyp. Antrochoanal is also known as the Killian's polyp. Antro means the maxillary sinus. Choana means the posterior opening of the nose. Right? Posterior opening of nose is known as choana. So a polyp which arises from the maxillary sinus and goes towards the choana is known as the antrochoanal or Killian's polyp, which is usually unilateral polyp seen mainly in adults. Okay, so yeah, sorry, seen mainly in children. Seen mainly in children. So here neither she is a child, neither it is like a polyp arising from the maxillary sinus, and no issues of maxillary sinusitis because no discoloration vagara seen. Moving further to question number 23, it states a patient was diagnosed with cancer larynx with involvement of one side along with fixation of vocal cord. The TNM stage of this cancer is. Now tell me the answer, guys. The TNM staging of this cancer is. So now if we talk about the cancer larynx, guys, cancer larynx can involve either the supraglottis, it can involve the glottis, or it can involve the subglottis. I hope you know glottis means the vocal cords. The area above glottis is known as supraglottis, below is known as subglottis. Okay. So please remember, let's study the cancer larynx. So usually cancer larynx is commonly seen in males. Cancer larynx is commonly seen in males between the age of 40 to 60 years. Between the age of 40 to 60 years, right? Important. Okay, and important risk factor would definitely be smoking. If we talk about the TNM staging, guys, which has been asked previously also. So please remember, TNM staging has 4 stages, T1 to T4. T1 means when only one structure is involved. When one structure is involved, it is known as T1. Okay, one structure on the same side, if it is involved, it is known as T1. If more than one structure is involved, it is known as T2. When more than one structure is involved, it is known as T2. When there is vocal cord fixation, okay, it is known as T3. Whenever the vocal cords would be immobile or the cancer has engrossed the vocal cords also, the vocal cord is not able to move, then it would be immobile vocal cord. Okay, vocal cord fixation is T3, and T4 would be any extra laryngeal extension. Okay, either the extension to the thyroid cartilage or any extra laryngeal extension would be considered as T4. Okay, at least remember the T staging, and M's are not important. M is what? Metastasis. If there is metastasis, then there would be M1. Right? So please remember, in this case what he has given, cancer larynx, involvement of one side along with fixation of vocal cord. So the answer to this question would be option C, T3N0M0. A question from August 2020 FMGE. Okay, T3N0M0 is the TNM staging of this cancer larynx. Treatment, if we talk about T1 and T2 are usually treated by only radiotherapy. T1 and T2 are usually treated by radiotherapy. T1 and T2 are usually treated by radiotherapy. Whereas T3 and T4, they would be treated by total laryngectomy. There should be removal of the larynx, total laryngectomy along with radiotherapy. Okay, followed by radiotherapy rather. Okay, and here the radical neck dissection would also take place. Okay, because if there is a high chance of metastasis in T3 and T4, so a radical neck dissection, when we will check the all other lymph nodes, that will also take place. Okay, total laryngectomy with radiotherapy for stages 3 and 4, and stages 1 and 2 are treated by radiotherapy. And for stage T1, for stage T1 N0M0, yes, chemo is also given along with radiotherapy. We also give some drugs nowadays. So it is chemoradiotherapy which is given, chemoradiation. Okay, definitely chemoradiation is preferred, a better choice definitely. Okay, T1 N0M0 can also be treated with CO2 laser excision. So please remember, T1 N0M0 can also, that is the most primitive stage, that can also be treated with CO2 laser excision or CO2 laser cordectomy. Okay, CO2 laser chordectomy is performed usually. I hope it is fine with everybody. Then moving further, important point to be remembered, in cases of cancer larynx, we can perform high tracheostomy. In cases of cancer larynx, we can perform high tracheostomy. Usually tracheostomy is performed at which levels? Tracheostomy is usually performed at the level of second and third tracheal rings. Tracheostomy is normally performed at the level of second and third tracheal rings. Okay, right? Tracheostomy is mainly performed at second or third tracheal rings. But when the larynx has been damaged already, okay, if there is cancer of larynx, then we perform a high tracheostomy at the level of first and second tracheal rings. Okay, I hope this is a question. This was a question which has been asked, and I hope you remember it. I hope I can move forward. Very good. Now, question number 24 says a 35-year-old male, okay, a 35-year-old male presents with epistaxis. Conservative management was performed to stop the bleed. Okay, conservative management was performed to stop the bleed, but it fails. What will be the next step? So now everybody is quite aware what is epistaxis. Epistaxis means nose bleeding, right? Nose bleeding is known as epistaxis. The most common area of epistaxis is Little's area. What is Little's area? So Little's area, this part, okay, the antero-inferior part of the nasal septum, okay. So this is your nasal septum. So this antero-inferior part of the nasal septum is known as your Little's area, which contains which plexus? It contains the Kieselbach's plexus. It contains which plexus? It contains the Kieselbach's plexus. And Kieselbach's plexus is actually a combination of 4 arteries, okay. It is a plexus or a network of 4 arteries. Most important one is your sphenopalatine artery, because sphenopalatine artery is the most common artery to bleed in cases of epistaxis. Therefore, it is also known as artery of epistaxis. Artery of epistaxis is sphenopalatine artery. Artery of epistaxis is sphenopalatine artery. Artery of epistaxis is sphenopalatine artery. Next is your greater palatine artery. Greater palatine artery. Third is your anterior ethmoidal artery. Third is your anterior ethmoidal artery, and the last one is superior labial artery. Fourth one is superior labial artery. So these forms the Kieselbach's plexus, and this can definitely be asked as an exception, which has been asked already. Instead of one of the arteries, they will give you posterior ethmoidal artery. So please remember, posterior ethmoidal artery is not a part of the Kieselbach's plexus. Okay, it is a part of rather a Woodruff's plexus. Okay, posterior ethmoidal artery is a part of the Woodruff's plexus, which is the most common cause of posterior epistaxis. Injury to Woodruff's plexus can lead to posterior epistaxis. And injury to Little's area, Kieselbach's plexus, leads to anterior epistaxis, which is more common. Most common cause in children would be nose picking or fingernail trauma. Okay, children usually do nose picking, so that fingernail trauma is the most common cause in children for epistaxis. Whereas in elderly, the most common cause of epistaxis is hypertension. Uncontrolled hypertension can lead to epistaxis in elderly, and more common type of epistaxis in elderly would be posterior. Mostly they will complain of posterior epistaxis. Okay, now if we talk about the treatment, guys, management is important. The first line management, if the patient would not have done anything, okay, not have done anything, directly presented to you with epistaxis, then the first line management would have been, you need to pinch the nose. First line management would be pinch the nose, apply pressure. Okay, yeah, first line management would always be pinch the nose only, and make the patient sit leaning forward or bending forward, so he would not aspirate the blood. Okay, so first management would have been pinch the nose. This was a question which has been asked. What is the first line management? It is pinching the nose only, applying pressure. Then if this is not successful, then you actually perform a chemical cauterization, and this chemical cauterization is performed with the help of either of this. Either it can be silver nitrate, so you can use a silver nitrate solution, or you can use phenol, that is carbolic acid. So either silver nitrate or phenol or carbolic acid can be used for chemical cauterization. If it is still not done, then you can also use a cautery, electrical cautery. Okay, and if then also it is not done, then you can use definitely anterior nasal packing, or in cases of posterior, you can use a posterior nasal packing. But still, if the patient is complaining of bleeding, okay, instead of anterior nasal packing, now you need to perform ligation of the arteries which are bleeding. Okay, and this ligation of the artery which are bleeding, most commonly we say it is the artery of epistaxis, that is sphenopalatine artery. So we will try to ligate first of all the Option B, sphenopalatine artery ligation. Now, as the conservative management, that is pinching nose, chemical cauterization, anterior nasal packing, all has failed in this patient. So the first step in surgery would be sphenopalatine artery ligation. If sphenopalatine artery ligation is not successful, then you will try to ligate the maxillary artery. Okay, you will ligate the maxillary artery. Third, if maxillary artery ligation is also not successful, then you will ligate the external carotid artery. Okay, external carotid artery, important, because external carotid artery is ligated also, there would be development of collaterals from it, okay, which will supply the brain. Don't worry about that. Okay, and mainly external carotid artery supplies the neck. Okay, internal carotid artery ligation should not be done, otherwise the patient will definitely go like the die within few minutes only. Okay, the patient will definitely die. So please remember, it is a very important aspect that you need to perform. After this, if the patient is still bleeding even after ECA, okay, even after ECA ligation, then definitely the source of bleeding is usually your ethmoidal arteries. Okay, the source of bleeding even after ECA ligation, if the patient is bleeding, it is your ethmoidal artery, and ethmoidal artery ligation should be performed. I hope this is clear with everyone. Epistaxis common hai. There have been questions on Kieselbach's plexus, on the first line management, and also on the same question had come earlier. Moving further, question number 25, easy one. Yeah, after ECA it is the ethmoidal artery, never ICA. Question number 25, endolymph is secreted by. Endolymph, I hope all of you are quite aware of inner ear. Inner ear is usually of two types: the membranous inner ear, which is the actual inner ear, which is responsible for hearing vagera, and second is the bony inner ear, that is just your bony cover of the labyrinth or the inner ear, right? Inner ear is also known as the labyrinth. Membranous labyrinth is usually made up of the cochlea, right, which is almost 2 3/4 turns. There are 2 3/4 turns of cochlea, everybody knows this. Then there is a vestibule, I told you, and this vestibule is made up of two important structures, that is utricle and the saccule. Till the time you answer, I'll explain. Okay, so vestibule usually is made up of utricle and saccule, and lastly are the semicircular canals. These are 3 in number: the posterior semicircular canal, the lateral semicircular canal, and the superior semicircular canal. I hope you know this structure of the inner ear, right? So vestibule में हमने देखा, there were the otoconia or otoliths. If they get displaced from the place, they will lead to BPPV, right? Semicircular canals we'll discuss further. Cochlea is responsible for hearing. So if this is a cross section of the cochlea, okay, this is known as your scala vestibuli, this is scala media, and this is scala tympani, right? This membrane which separates the scala vestibuli and scala media is known as the Reisner's membrane. Okay, the Reisner's membrane. Then the membrane which actually separates media and tympani is known as the basilar membrane. And on the basilar membrane, we have this organ of Corti. We have this organ of Corti which is responsible for hearing, right? Organ of Corti is a sensory end organ of cochlea. Okay, it is a sensory end organ of cochlea which is responsible for hearing, right? And it is covered by a membrane. This membrane is known as the tectorial membrane. It is covered by a tectorial membrane. I hope all of you are quite aware of this. And this scala media is actually lined by a vascular layer, and this is known as stria vascularis. This is known as stria vascularis, and this stria vascularis is responsible for endolymph production. I hope it is fine. Endolymph secretion is the responsibility of stria vascularis. I hope it is fine. And endolymph drainage is the responsibility of the endolymphatic sac. Okay, endolymphatic sac is responsible for the endolymphatic drainage, right? And there is also one more fluid which is present in the tympani and vestibuli, that is your perilymph, which is nothing but the CSF only. Okay. Then question number 26, guys. The semicircular canals are mainly responsible for. So now they are asking, what is the function of the semicircular canals? I hope we have seen all the 3 structures of inner ear or labyrinth now. Cochlea, we said it was responsible for hearing. Second, it is your vestibule that is contains of your utricle and saccule, which were responsible for utricle and saccule are responsible for anybody. Yeah, it is rich in potassium. The perilymph, as compared to the CSF, it is rich in potassium. Very good. So the answer to this question, semicircular canals are responsible for option A, angular acceleration. They are responsible for angular acceleration or angular balance, you can see. Important. Okay, how are semicircular canals placed? This is the lateral, this is the superior, this is the posterior. So they are placed at angles, right? So it can be easily remembered. Okay, so they are placed at angles to each other. Therefore, they are responsible for angular acceleration or angular balance. The one which is responsible for linear balance or linear acceleration is the vestibule. That is your utricle and saccule. Linear acceleration is the responsibility of utricle and saccule. Hearing is the responsibility of cochlea, right? Important. And the sensory end organ of cochlea is known as organ of Corti. I hope everything is fine. Okay, I hope everything is fine. Not all of the above. All of the above हमेशा आंसर नहीं होता है. Okay, please remember this. I hope everything is fine with this. Moving further to the next one, guys. Now, moving further to question number 27. Now, a very important and a commonly asked question, repeated one also. A patient presented with history of fever, throat pain, and difficulty in swallowing. On inspection, you find that the uvula is deviated from the midline. So this is what is your uvula, right? And it is deviated from the midline. Likely diagnosis is. Along with that, they have given an oropharyngeal picture also. Okay, this is a tongue depressor which is used, a spatula, oropharyngeal spatula. Okay, so here we can see the arrow has been marked. Here we can see a swelling in the tonsils. Okay, so in and around the tonsils, a swelling is seen due to formation of abscess. Right? And the uvula is shifted to other side. Right? And the patient complains of history of fever, throat pain, and difficulty in swallowing. Difficulty in swallowing is known as dysphagia. Difficulty in swallowing is dysphagia. Along with that, there would be throat ache. Okay, and along with that, sometimes the patient complains of difficulty in opening the mouth due to spasm of the medial pterygoid muscle, and the difficulty in opening of mouth is actually known as trismus or lockjaw. It is known as trismus or lockjaw. So these three important features, along with this oropharyngeal picture where there is accumulation of pus. Okay, there is accumulation of pus in between the tonsils and the tonsillar bed. Okay, accumulation of pus in between the tonsils and its bed. Okay, between tonsil and its bed, it is known as what? This condition is known as quinsy. This condition is known as quinsy. Option D. Quinsy is actually nothing but a peritonsillar abscess. Important. Quinsy is a peritonsillar abscess. Okay, so it is actually a peritonsillar abscess where there is accumulation or accumulation of pus between the tonsil and the tonsillar bed. Okay, and that is the reason why the tonsil would be protruding into the midline and the uvula would be shifted towards the other side. Important feature, right? Most common age. So please remember, tonsil usually affects adults. Quinsy usually affects adults. Okay, quinsy usually affects adults, right? The symptoms I have already told you. It is throat ache, dysphagia, and trismus. Okay, throat ache, dysphagia, and trismus. The treatment in this condition would be incision and drainage. But here, this time we are going from inside. It is a per oral incision and drainage. It is a per oral incision and drainage because please remember, no swelling, no neck swelling is seen in cases of quinsy. Important. Usually, no neck swelling is seen in cases of quinsy. It is just a swelling in the inside. No outside appreciable swelling would be seen in cases of quinsy. Yaad rakh lena. Okay. Second differential diagnosis was this retropharyngeal abscess. Retropharyngeal means behind the posterior pharyngeal wall. Okay. Retropharyngeal abscess. Sorry. Most commonly, it is usually seen in children. Retropharyngeal abscess commonly is seen in children. Okay, important. And how do we differentiate? Because the symptoms would be same. Throat pain, fever, dysphagia, all of these symptoms would also be there in retropharyngeal abscess. But if you take a X-ray soft tissue neck, okay, if you take a X-ray soft tissue neck, usually a lateral view is preferred. In this lateral view of X-ray soft tissue neck, you will find widening of the prevertebral shadow. Okay, widening of the, I have included this in the images only. You can find it over there. Okay, widening of the prevertebral shadow. Okay, and this widening of prevertebral shadow is due to accumulation of pus. Okay, so accumulation of pus occurs in the retropharynx, and that is the reason why there is widening of prevertebral shadow. And how to differentiate it from prevertebral abscess then? Okay, So please remember, prevertebral abscess is usually seen in adults, okay? But please remember, on X-ray soft tissue neck, symptoms are again the same. But on X-ray soft tissue neck, on lateral view usually, you will find first of all, widening of prevertebral shadow. First, it would be seen definitely because there is accumulation of abscess over there also. So why it is called as a prevertebral abscess then? Because there is involvement of the vertebrae also, rather there would be erosion of the cervical vertebrae. Erosion of the cervical vertebrae. So X-ray soft tissue neck, if it shows only widening of prevertebral shadow, it is known as retropharyngeal abscess. And if it shows X-ray soft tissue neck lateral view shows two features, widening of prevertebral shadow along with erosion of cervical vertebrae, it is known as prevertebral abscess. I hope this is fine with all of you. Now you can rule out it easily, right? And important thing, in retropharyngeal abscess, no swelling is usually seen as such, okay? Neck swelling can be seen at times, but usually no swelling is seen. In parapharyngeal abscess, you can see a neck swelling. In parapharyngeal, you can see a neck swelling. In Quincke's disease is what? It is nothing but angioedema of the ovula. Okay, if this ovula is swollen, angioedema of ovula is known as Quincke's disease, which is treated with steroids. Moving further, question number 28. Stimulation of external auditory canal leads to cough due to which nerve? Now, when you are actually scratching your external auditory canal or external auditory meatus, this EAC scratching can lead to a cough reflex. And this is due to which nerve? This is due to which nerve? I hope you are aware that our 10th cranial nerve, I hope you are quite aware that our 10th cranial nerve, that is our vagus nerve, right? 10th cranial nerve, that means our vagus nerve innervates two important structures, right? So the 10th cranial nerve or the vagus nerve, okay, it also innervates your GIT and it also gives a branch to your middle ear, right? It also gives a branch to your your external auditory canal. It also gives a branch to your external auditory canal, also to the middle ear, okay, right? Yeah, very good. So I'll inform you about surgery, don't worry, okay? So 10th cranial nerve or the vagus nerve, so it also gives innervations to the GIT, also to the external auditory canal. And this external auditory canal, it is innervated by the auricular branch of the vagus nerve. Auricular branch of the vagus nerve. Auricular branch. I hope it is fine. Okay. Whereas in GIT, it gives innervation via, in larynx usually. Okay. In larynx usually, it gives innervation via two important nerves. That is RLN and SLN. As we have studied earlier, recurrent laryngeal nerve and the superior laryngeal nerve, both of them are a branch of vagus nerve. Okay, both of them are a branch of 10th cranial nerve, that is vagus nerve, RLN as well as SLN. So whenever you will try to irritate vagus nerve at any of its point, whether it is the external auditory canal, that will elicit the cough reflex. Okay, that will elicit the cough reflex, because at any point vagus is irritated, the other structures would also elicit a reflex, and therefore the RLN and SLN would also be stimulated, leading to a cough reflex production in the larynx. I hope this is fine. And this auricular branch of vagus nerve, everybody of you are right, it is also known as your Arnold's nerve. This was a question. Also, it is known as the Alderman's nerve. So, auricular branch of vagus nerve is also known as Arnold's nerve or Alderman's nerve. Right? If we talk about nerve supply of external auditory canal, it has been asked earlier. So please remember, the posterior wall and the floor of the external auditory canal is innervated by the auricular branch of vagus nerve. Okay, important. So posterior wall and floor of EAC are innervated by the auricular branch of vagus nerve or the Arnold's or Alderman's nerve. The pinna, majorly the pinna or the lobule of pinna is innervated by the greater auricular nerve. Major innervation of pinna is done by the greater auricular nerve. Then anterior wall and roof are innervated by the auriculotemporal nerve. Okay, anterior wall and the roof of the EAC are innervated by the auriculotemporal nerve. Whereas the posterior superior part of EAC is innervated by the nerve of Wisberg. Anybody? Nerve of Wisberg is a branch of nerve of Wisberg. It is a sensory branch of anybody. It is a sensory division of which nerve? So it is a sensory division of 7th cranial nerve, that is your facial nerve. So important. So nerve of Wisberg is the sensory division or the sensory branch of your 7th cranial nerve. It is nothing but the auricular branch of your 7th cranial nerve or facial nerve, also known as nerve of Wisberg. I hope this is clear with everybody. Moving further. Talking about question number 29, it states a 23-year-old singer presents to you with hoarseness of voice and difficulty to sing higher notes lately. The laryngoscopy picture is given below. What is the best management? So we need to tell about the best management. We need to tell about the best management. Harsh, that you are talking about glossopharyngeal nerve. Important you need to remember is glossopharyngeal nerve is or the ninth cranial nerve. It is usually located in the tonsillar bed. Okay, just clearing your doubt. It was also a question. That's why it is usually located in the tonsillar bed. So whenever a patient is having tonsillitis, there would be referred otalgia. There would be referred ear pain. Okay. So referred ear pain is also known as referred otalgia. So a tonsillitis can lead to ear pain. This is due to the glossopharyngeal nerve or the ninth cranial nerve, which is located in the tonsillar bed and it innervates the ear also. Right? That is what is referred otalgia. All of you are right. Yes, important. So a 23-year-old singer presents to you with hoarseness of voice, difficulty to sing higher notes, means high frequency notes. Laryngoscopy picture shows us these arrows are usually given. So here we can find a bilateral condition. Okay, at what junction we can find it? Okay, the most common site is at the anterior 1/3 and the posterior 2/3. Important. Okay. So anterior 1/3 or the posterior 2/3 of vocal cords, we find these nodular structures. These are nothing but vocal nodules. So a bilateral nodular structure on the vocal cords at the anterior 1/3 and posterior 1/3 junction is your vocal nodules, which are usually known as teacher's nodules, right? Because teachers needs to speak for a longer period of time. Screamers nodules, those who scream or do vocal abuse. Okay, and screamers nodules, and also they are known as singers nodules because singers also need to sing a lot. Therefore, repetitive irritation of that vocal cord can lead to this vocal nodules. Most common cause is vocal abuse. Most common cause is usually vocal abuse. Okay. I feel this is fine. Vocal abuse is the most common cause. मेरे को भी vocal nodules होने वाले हैं. I'll develop it very early. So the treatment of choice in vocal nodules is definitely speech therapy. Okay, so please remember the treatment of choice in cases of vocal nodules is speech therapy, preferred over voice rest. Voice rest can also be done, guys, but the best treatment would be speech therapy. Okay, it is usually speech therapy. Oral steroid therapy is not given. CO2 laser excision is done in cases of polyps. Okay, so if we talk about vocal polyps, or also known as juvenile polyposis of larynx. Okay, so these vocal polyps are usually seen in adolescent age. Okay, these vocal polyps are usually seen in adolescent age, or they can also be seen in children. Okay, they can also be seen in children. And vocal polyps are mainly due to HPV, that is human papilloma virus, mainly strains like 6 and 11, out of which 6 is more common strain, 11 is more virulent strain. Okay, and these HPV can lead to this polyps also at times. Okay, so please remember. And vocal polyps, the most common site is usually speech therapy लेनी पड़ेगी. हाँ, vocal polyps की most common site, please remember, it is the anterior 2/3. It is the anterior 2/3 and the posterior 1/3. Okay, it is the junction of the anterior 2/3 and the posterior 1/3. Okay, it is the junction of anterior 2/3 and the posterior 1/3. Yeah, any issues? Any issues, Harsh? I hope everything is fine. So vocal polyps की most common site is usually anterior 2/3 and the posterior 1/3, and the management usually would be CO2 laser excision or a microlaryngeal surgery. We prefer doing a microlaryngeal surgery. Okay, and microlaryngeal surgery is performed with the ENT microscope. I hope you know the ENT microscope wavelengths that can be asked. ENT 200, 300, 400. At least remember this. Okay, and this MLS can also be a mnemonic for your thyroplasties. Okay, MLS is also a mnemonic for thyroplasty. That is type 1 thyroplasty. Type 1 thyroplasty is for medialization of vocal cords. Type 2 thyroplasty is for lateralization of vocal cords. Type 3 thyroplasty is for shortening of vocal cords. And type 4 जो बचता है अभी, that is for lengthening of vocal cords. ठीक है? So MLS is also mnemonic for all types of thyroplasty. I hope this is fine with everybody. Moving further, question number 30 now. All below given are true statements about nasopharyngeal carcinoma except सबका favorite आ गया. Everybody knows this now, right? Everybody knows this. No, no, no. Location is not same for polyps and nodules. Please remember that is different. Sorry. Yeah, yeah, yeah. For polyps and nodules, usually the location is same. Sorry. For polyps and nodules, the location is same. It is anterior 1/3 and posterior 2/3. For polyps and nodules, the location is same. Thank you for correcting. It is anterior 1/3 and the posterior 2/3. Whereas the location is different in cases of intubation granuloma. The location is different in cases of intubation granuloma. Sorry. Just correct yourself, guys. Polyps में the location is same as that of for vocal nodules, anterior 1/3 and posterior 2/3. Sorry for that mistake. And intubation granuloma, it is the other way around. That means your anterior 2/3 and posterior 1/3. I hope this is fine, because during intubation, the most commonly injured part will be your junction of anterior 2/3 and posterior 1/3. Moving further, all below given are true statements about nasopharyngeal. Nasopharyngeal carcinoma is more common in adults. Okay, it is more common in adults. Adult males or females? NPC is more common in adult males or females? Please tell me. It is more common in the Chinese race, as all of us know. Okay, most common site. Let's start with the statements itself now. Okay, all below given are true statements about nasopharyngeal carcinoma, except, so we need to find the wrong statement now. Okay, so wrong statement बतानी है. Statement 1, option A says it is associated with Epstein-Barr virus otitis media. Or serious otitis media, but it is not the most common presentation. So option D is the wrong statement. Most common presentation is not unilateral conductive hearing loss, rather it is your cervical. I hope it is fine now. I hope it is fine. So now the most common presentation. So please remember, the most common presentation of nasopharyngeal carcinoma would be cervical lymph node metastasis. Cervical lymph node metastasis. Okay. Most common presentation is cervical lymph node metastasis or lymphadenopathy, you can say. Okay. Enlargement of, yeah, it is painless. Very good. It is painless. Painless cervical lymphadenopathy due to metastasis from the NPC. Nasopharyngeal carcinoma is the most common presentation. And NPC is treated by, treatment of choice is chemoradiation. Most common site fossa of Rosenmuller, associated with EBV infection. Unilateral conductive hearing loss is seen, and the triad seen is the Trotter's triad. Triad seen is the Trotter's triad, right? Mnemonic was UPD. U for unilateral conductive hearing loss due to glue ear or a serous otitis media due to eustachian tube blockage. P for palatal palsy due to 10th cranial nerve involvement, and T for trigeminal neuralgia. Right, trigeminal neuralgia or your temporoparietal pain due to involvement of the 5th cranial nerve. I hope that is fine. Moving further, question number 31. A patient complains of pain behind the pinna. Okay, pain behind pinna means the retroauricular pain. Pain behind pinna is a retroauricular pain, and there is a profuse pus discharge from the right ear which fills up immediately after cleaning. What is the diagnosis? A very important and a very common question. Very easy also. Patient complains of retroauricular pain. Pain behind pinna. Retroauricular pain. And there is profuse ear discharge. A lot of ear discharge is coming from the right ear. Okay, which fills up immediately after cleaning. And when a ear discharge is filling up immediately after cleaning, that means the ear discharge is not actually from the ear. Rather it is from the mastoid. Okay, the mastoid is actually sending more and more pus towards in the ear. Okay, and this is known as the reservoir sign. This is known as the reservoir sign. So when there is profuse ear discharge and the ear discharge fills up again after cleaning immediately, this is known as the reservoir sign. Okay, reservoir sign can be seen. Okay, yeah, very good. And this would be seen, that is your ironed out mastoidal surface, and this ironed out mastoidal surface is known as the battle sign. Ironed out this is the first sign usually. Okay, this is the first sign. This is also known as battle sign, but usually this is the first sign, that is your ironed out mastoid surface in cases of mastoiditis. So the answer in this question would be option C, mastoiditis. Right, retroorbital pain along with profuse ear discharge and with reservoir sign. Okay, so please remember guys, in ASOM also there would be profuse ear discharge, right? ASOM also there can be profuse ear discharge, but please remember there would be ear pain, not retroauricular pain. No retroauricular pain would be seen, rather there would be pain in the ear, that is otalgia would be there. right? Petrositis, we have seen Gradenigo syndrome, right? There was a triad, diplopia vagara tha. And CSM, we have discussed both types of CSM now in details. Okay, the signs usually which are seen are the reservoir sign and the second sign. That means the pus column seems to be fluctuating, and this pus column, if it seems to be fluctuating, this is known as the lighthouse sign. So two important signs of mastoiditis: reservoir and lighthouse. Two important signs of mastoiditis: reservoir and lighthouse sign. Okay, what will be the treatment? MRM. Treatment is MRM, that is modified radical mastoidectomy. You need to remove the mastoid bone, okay, and clean it. Okay, modified radical mastoidectomy. Surgical landmark for modified radical mastoidectomy. Very good, Harsh. Why you related it? The surgical landmark is Mac-Evans triangle. The surgical landmark would be Mac-Evans triangle. Important. Okay, Mac-Evans triangle, also known as the suprameatal triangle. It is also known as the suprameatal triangle. Okay, just over your external auditory meatus there is a triangle. Okay, so that is your suprameatal triangle or external Mac-Evans triangle, which is a landmark for your modified radical mastoidectomy to locate your actually antrum. Okay, question number 32 says a patient was brought to the hospital with complaints of deviation of the mouth and hyperacusis. Okay, hyperacusis means loud sound appears more loud. Okay, a loud sound appears more loud, that is known as hyperacusis. The preferred management in this case, this was the image which was given, right? There is deviation of the mouth. What is this? Everybody knows now. This is facial nerve palsy, right? This is facial nerve palsy, rather Bell's palsy. Idiopathic facial nerve palsy is known as what? Idiopathic facial nerve palsy is known as Bell's palsy. So seventh cranial nerve facial nerve palsy thi hai. There is deviation of mouth, and deviation of mouth, it is towards the normal side. So please remember, deviation of mouth in facial palsy is towards the normal side. That means if this side of deviation is seen, that means this nerve is affected usually. Okay, the left nerve is affected, left facial nerve in this case. So the preferred management would be what? Very good, all of you are right. The preferred management in this case would be option C. We need to start oral steroid therapy. Okay, if we talk about facial palsy, the most common cause would be idiopathic. Most common cause is idiopathic. Now they say there has been association of HSV infection, herpes simplex virus infection also in facial palsy, and therefore we use acyclovir also in the treatment regime. We can use acyclovir also. Okay, but the preferred management usually is to start a oral steroid therapy which decreases the edema surrounding the facial nerve, and therefore there would be no compression of facial nerve and the condition will improve. Start oral steroid therapy. But after 3 weeks of oral steroid therapy also, after 3 weeks of steroids, the patient's condition is not improving. Okay, after even 3 weeks of steroids, the patient's condition is not improving. Then we need to do a electrophysiological nerve testing. Then we do a electrophysiological nerve testing. And on electrophysiological nerve testing, if we find if there is damage of the nerve, if we find there is damage of the nerve, yes, it is element type. Very good, it is element type only. If there is damage of the nerve fibers, then we actually perform a surgery. Okay, and that is your surgical decompression of the nerve. This surgical decompression is performed. Okay, and this surgical decompression, in this we actually pull out the labyrinthine part of the nerve. Okay, because labyrinthine part of facial nerve is the narrowest portion. So there is most chance, like higher number of chances of compression in the labyrinthine part of the nerve. Therefore, we do a surgical decompression of the nerve as a final treatment. Okay, and physiotherapy would be done for just what we can say rehabilitation. It is not the treatment of choice or the preferred management. Ramsay-Hunt syndrome, it is due to herpes zoster virus. Okay, it is not due to herpes simplex, it is due to herpes zoster virus. Usually, if a patient was affected with chickenpox in childhood and the virus has stayed there, then it can again reappear or reactivate, okay, in the ganglion. And this, if it reactivates in the trigeminal ganglion, it would involve the ear or the eye, and that is known as Ramsay-Hunt syndrome. If it involves the eye, herpes zoster oticus is known as Ramsay-Hunt syndrome. I hope this is clear. Right. Moving further, question number 33. A 36-year-old male patient is suffering from recurrent episodes of hearing loss, vertigo, nausea, and tinnitus. The episode settles down in a day. Okay, important. The episode settles down in a day. The patient avoids noisy areas. Possible diagnosis is, I hope everybody is clear with this. Okay, most common age this disease affects is usually adult females. Okay, usually in the third or fourth decade. It usually affects adult males, and for males, right, in their third or fourth decade. So usually adult males are commonly affected in this condition in the third or fourth decades, right. Phenomena which is seen, it is this one: the patient avoids noisy areas because the patient rather feels very much like the stupor is in cases of noisy areas. Okay, and this is known as recruitment phenomena. Okay, so patient tries to avoid noisy areas because he gets irritated with noisy areas. So this is known as the recruitment phenomena. Or due to sudden exposure to noise, he can even fall down. Okay, due to sudden exposure to noise, he can even fall down. This is known as Tullio's phenomena. So two phenomena are seen: recruitment phenomena and Tullio's phenomena can be seen. Alright, a pure tone audiometry if performed. This is the pure tone audiometry which will show a rising audiogram. कैसा दिख रहा है? Rising audiogram. Okay, so previously he had previously he has hearing loss for lower frequencies. Now he has hearing loss for higher frequencies. This is known as a rising audiogram. So a rising audiogram is seen. Three features: recruitment phenomena, Tullio's phenomena. Yeah, otosclerosis patient feels better in noisy areas because he can at least hear in noisy areas. That is known as paracusis villi. But this patient tries to avoid noisy areas because his understanding falls usually in noisy areas. He could not understand, or he could not withstand that much of noise. He can rather fall down. That is known as Tullio's phenomena, right? Pure tone audiometry we have discussed. It shows a rising audiogram. Yeah, Tumor-Crin's crisis can also be seen. Tumor-Crin's crisis, just an exposure to loud sound, the patient can definitely go in syncope. Okay, without any support. The patient feels that I do not have any support, and the patient can fall down suddenly. Okay, so a rising audiogram is seen on a PTA, and treatment would be what? Anybody? So this, all that we have discussed, is a case of Meniere's disease. Okay, important. Meniere's disease is an episodic disease. Meniere's disease is a episodic disease. So there would be episodes of three important features, and the episodes are of these triad, that is fluctuating hearing loss. Next, that is vertigo, which is associated with nausea and vomiting, and third is a tinnitus. So three important features of Meniere's disease would be hearing loss, then there would be vertigo, which is associated with nausea and vomiting, and then there would be tinnitus. Okay, this is a feature of Meniere's disease, but there would be episodes of these, and these episodes generally settle down in 24 hours or within a day. Okay, this is known as Meniere's disease, which is also known as endolymphatic hydrops. Meniere's is also known as endolymphatic hydrops. Why it is known as endolymphatic hydrops? Because as we have seen earlier, that this endolymph, which was produced by the stria vascularis, it is drained by the endolymphatic sac. But if the endolymphatic sac is not able to drain this endolymph properly, there will be increased level of endolymph in the ear, which will lead to increased pressure, and this excess pressure can lead to damage of the cochlea, and this damage of cochlea over a period of time can lead to hearing loss, which is seen in Meniere's disease. Okay, first it would be episodic, and then when it progresses further, there would be a continuous hearing loss. In between episodes also the person will experience hearing loss, right? And this is also known as glaucoma of ear. Very good. It is also known as glaucoma of ear. Treatment may usually give anti-vertigo drugs like promethazine वगैरह can be given. Anti-vertigo drugs can be given. Also, to decrease the pressure, we can give some carbonic anhydrase inhibitors like acetazolamide, right? Carbonic anhydrase inhibitors can be given. Or if on all these treatment, on medical treatment, if the patient is not responding, then we can perform a endolymphatic decompression surgery. And this endolymphatic decompression surgery, for this the landmark is the Donaldson's line. Okay, for this the landmark is the Donaldson's line. So endolymphatic decompression surgery can be performed. Right. So the answer to this question 33 is Meniere's disease, which is episodic glaucoma of ear, you can say, or endolymphatic hydrops, commonly seen in adult males. Recruitment, Tullio and Tumor-Crin's phenomena, rising audiogram, anti-vertigo drug. Just for my sake, for my knowledge sake, can anybody share with me sloping audiogram on PTA is a feature of sloping audiogram? Matlab, this is a rising audiogram, so opposite. This is a sloping audiogram. Sloping audiogram is a feature of. Please tell me that. In the meanwhile, I'll tell you about this audiometry. So this is a pure tone audiometry in which you can see a dip at the 4000 hertz, right? A dip at 4000 hertz is seen. And if there is a dip at 4000 hertz, it is due to what? So this is due to noise induced hearing loss. A dip at 4000 hertz is known as a acoustic dip. Okay, this is known as a acoustic dip in cases of noise induced hearing loss. So at least you need to remember this. Carhart's notch 2000 hertz per dip, otosclerosis. 4000 dip per acoustic dip, noise induced hearing loss. Rising audiogram, Meniere's disease. Sloping audiogram, very good. Age-related hearing loss, that is presbyocusis. Sloping audiogram is a feature of presbyocusis or age-related hearing loss. Moving further. Question number 34 now. A 40-year-old female with pulsatile tinnitus and red bleeding mass in the external auditory canal. The mass blanches on seagulization. Which sign can be seen on a CT head? 40-year-old female, so adult female is commonly affected with this disease, very clear from the question. Pulsatile tinnitus is seen, right? Pulsatile means maybe some artery vein would be affected, mainly artery would be affected if there is a pulsatile tinnitus. Red bleeding mass is seen in the external auditory canal, right? So red bleeding mass in a young adult, in a adult female with pulsatile tinnitus is nothing other than what? It is, the diagnosis is Glomus jugulare. The diagnosis in this condition is a tumor of the jugular sinus, that is your Glomus jugulare. Okay, and first of all, this Glomus jugulare, in the early stages, this glomus tumor, it is just beneath the inferior wall of your external auditory canal. So it can invade the floor of the inferior orbital canal, inferior auditory canal, and then it can just protrude into your external auditory meatus. And if it protrudes into your external auditory meatus, this would be seen as a rising sun sign. कौन सी sign दिखाएगा? It would be known as your rising sun sign. So if the glomus tumor invades the floor of the external auditory meatus and goes into the external auditory canal, it is seen as a rising sun. Therefore, it is known as a rising sun sign. Okay, important. And it can also further protrude. It can also further invade the middle ear, and then there will be a red bleeding mass along with some bleeding that can be seen in the external auditory canal. Along with that, there would be pulsatile tinnitus, and the mass will blanch on seagulization. And when the mass will blanch, okay, whenever you put pressure via the Seagal speculum, I hope you have seen the Seagal speculum, you can see in the images. Whenever Seagal speculum say you try to exert some pressure on the mass, there would be blanching. Okay, the color would go down. There would be pallor or blanching of this mass, and this is known as the Brown sign. This is known as the Brown sign. So I hope we are clear. Glomus jugulare on seagulization, Brown sign, invasion of floor of external auditory canal, rising sun sign, and on a CT head we will find this option C, Phelps sign. Okay, Phelps sign is actually due to erosion of the septum. Okay, it is due to erosion of the septum between the carotid canal, erosion of the septum between the carotid canal and the jugular foramen. Okay, between the carotid canal and the jugular foramen. I hope this is fine. This is known as a Phelps sign, which is seen on a CT head. Okay, this is a Phelps sign. Rising sun sign is again seen over here. Battle's sign is seen in cases of mastoiditis, right? Battle's sign was seen in cases of mastoiditis vagara when there is discoloration of the mastoid surface, reddish discoloration of a mastoid surface, right? It is usually seen as a mainly. It is not rather characteristic feature of mastoiditis, rather mainly it is a characteristic feature of middle cranial fossa fracture. Important. Battle's sign is a characteristic feature of medial cranial fossa fracture. Whenever there is a medial cranial fossa fracture, there would be reddish discoloration of the mastoid surface. This is known as the Battle's sign. Okay, this is nothing but just what we can say, ecchymosis, right? Option A, delta sign, very good. It is seen in cases of not unsafe CSOM. It is seen in cases of sigmoid sinus thrombosis. Yeah, it can be seen as a complication of CSOM for sure, but unless and until sigmoid sinus thrombosis is not present, delta sign would not appear mainly. Okay, so involvement of sigmoid sinus thrombosis would lead to delta sign on CT head. Okay, last question for today. Question number 35. A resident of a small village in Tamil Nadu presents with nasal mass as given in the image and epistaxis. What is the possible diagnosis? So he is a resident of Tamil Nadu, presents with nasal mass as given in the image and there is epistaxis also, bleeding. What is the possible diagnosis? Anybody? So Tamil Nadu is a endemic state for this disease, first thing. Next, this disease is usually seen when the people usually bath in a dirty pond. Okay, when people bath in a dirty pond, it can also be an important risk factor. Okay, dirty water में अगर bath लेते हो तुम, right? And this mass which is seen in the nose, it gives appearance of mulberry. So a mulberry appearance of nasal mass, mulberry appearance of nasal mass. Okay, so these three are characteristic features of, very good, it is option A, rhinosporidiosis. And rhinosporidiosis is caused by Rhinosporidium seaberi, which is an aquatic protozoa. Therefore, it is acquired from water itself. Okay, so it is a Rhinosporidium seaberi, which is acquired from water. It is an aquatic protozoa, rhinosporidiosis, which leads to appearance of this mulberry appearance in the nasal mass. I hope this is fine. Can anybody tell me mulberry appearance of nasal mucosa is given by? Mulberry appearance of nasal mucosa is given by. If I say mulberry appearance of nasal mucosa, that is a feature of. Mulberry appearance of nasal mass is feature of rhinosporidiosis. Mulberry appearance of nasal mucosa is a feature of. In that meanwhile, I'll tell you, rhinophyma, you can see images in snaps. Rhinophyma is nothing but hypertrophy of the sebaceous glands, right? What is rhinophyma? Hypertrophy of sebaceous glands of the external skin of the nose. Okay, hypertrophy of sebaceous glands of the external skin of the nose is usually known as rhinophyma, which is also known as potato nose. Rhinophyma is also known as potato nose. Rhinophyma is also known as potato nose. Om Puri mein dikhta tha. Rhinophyma was seen in Om Puri actor. If you can recognize him, you can search him. Okay, so you will find it. Then inferior turbinate hypertrophy. Very good. It is. So in inferior turbinate hypertrophy, we will find this mulberry appearance of nasal mucosa. Okay, mulberry appearance of nasal mucosa is seen in inferior turbinate hypertrophy, whereas inferior mulberry appearance of nasal mass in cases of rhinosporidiosis. Whereas in cases of rhinoscleroma is also known as woody nose. An important question, guys. I could not include the question over here, but you need to read rhinoscleroma at any point. Okay, this is the right answer, by the way. So rhinoscleroma is important. Rhinoscleroma is also known as woody nose. Okay, and rhinoscleroma is due to exposure to nickel dust. Okay, rhinoscleroma is due to exposure to nickel dust, or usually seen in woodworkers. It is usually seen in woodworkers, right? In woodworkers, we can find this also. But important cause, these are not the important causes, guys. So just remember the important one. Okay, there can be multiple features, but the important thing that you need to remember over here is only that the most common cause would be in rhinoscleroma, it is the Klebsiella rhinoscleromatis. Okay, here you will find Klebsiella rhinoscleromatis, which is the most common cause of rhinoscleroma. Klebsiella rhinoscleromatis. Okay, woody nose would be seen. Very good. Yeah, taper nose, Hebra nose, all of these are features. Very good. And if we take a biopsy of that particular rhinoscleromatis nose, then we will find two important features, that is Russell bodies and maculus cells. We can find Russell bodies and maculus cells. Okay, maculus cells are vacuolated cells, whitish cells dikhenge, and Russell bodies are usually basophilic blue colored bodies which are seen. Okay, so rhinoscleroma, important. And important, I am talking about woodworkers vagara na. Woodworkers mein mostly many of the features are seen. We can see multiple carcinomas, but please remember, woodworkers or nickel dust exposure is commonly associated with maxillary sinus carcinoma. Woodworkers are commonly associated with maxillary sinus carcinoma. The most common cancer that would be seen in woodworkers would be maxillary sinus carcinoma. So due to furniture dust or due to nickel dust, usually maxillary sinus carcinoma develops, and all of us are quite aware that maxillary sinus is the most common sinus for developing malignancy, right? And inferior turbinate hypertrophy, remember, it is usually seen in cases of DNS, deviated nasal septum, right? I hope with this I end the session for today. Thank you so much, and let's meet in the next session, guys. So yeah, thank you so much for this, and I'll inform you about surgery. Next standing sessions, I'll mostly start with surgery itself. Okay? Chalo, all the best. Keep studying hard. Good night. Take care. I'll send the PPT. Don't worry.